Some points from what we heard yesterday from all of the distinguished speakers. So I probably will not do the justice of telling all the stories comprehensively, so I apologize for that. But I'm trying to summarize it in a way that probably give you a sense of where does it fit in the framework that we saw since the first day of the course. Yeah. So if you remember, this is the frameworks that we are using. So yesterday on the first session, we look at the assessment part, and then the following sessions were all about the policy instruments and the modalities and mechanisms and how the policy instruments kind of affect the modalities or use in the modalities and mechanisms that you choose to do your integration efforts, whether it is organizational, whether it is functional, infrastructural, professional, and clinical. And that's what we discussed mostly yesterday. So organizational integration, functional integration, infrastructural integration, and also some clinical and person-centered integration. And the kind of policy instruments that were discussed yesterday was about the strategic purchasing. We heard a lot of strategic purchasing yesterday. And also the regulation. We also heard about social franchising, exhortation, and information. Yeah. So those are the policy instruments and modalities and mechanisms that we talked about yesterday. So let me remind you of some key points of the sessions from yesterday. So the first one was on the assessment, the private health sector assessment. And for the private health sector assessment, the main thing that you need to remember is that it has to be done with a specific health system goals in mind. Yeah. So you don't do private sector assessment just because you don't have anything else to do, but because you want to achieve something in the health system, and because you feel that there is something that is still lacking in the health system goal, and you want to engage the private sector, so you want to understand the private sector that you're going to engage with. Yeah. And then the way that you do your private health sector assessment should be able to help you choose the policy intervention that will suit your need, and that give you sufficient information to make that kind of choice, to choose a policy instrument that you want to do, to choose what kind of modalities and mechanism that you think can be better serve your health system. And the breadth or the depth of the information that you want to have from the private health sector assessment is really about how much do you want to understand about your private sector. So the more you want to understand about them, probably you will have a more breadth of issues that you want to cover. Or if you want to have a very specific or very targeted private health sector assessment, if you want to be very specific about this particular kind of service, for instance, if you want to only do some engagement in a certain disease, for diabetes, for instance, or for TB or whatever it is that you want to choose, then the depth of the information that you need to gather would be depending on how much do you need to know about that particular service in the private sector. And the other information that you need to gather in your private health sector assessment is about the linkage between the public and private sector. You need to understand their context, their environment. You need to understand what are the mechanisms that are available to them, what are the regulatory frameworks that is available to them, and so on and so forth. So those are the things that you want to achieve with your private health sector assessment. And I've tried to summarize all the kind of objectives, the different kind of objectives that you can do with your private health sector assessment, and hopefully with this in mind, you will be a bit more confident in embarking the private health sector assessment. In the PowerPoint, I also listed some of the reference that you can use, as in what kind of tools that you can do or you can choose to do your private health sector assessment. So the idea is that the private health sector assessment is done with an objective in mind, and then the outcome of it should be helping you to do some kind of a policy instrument that you can use to engage the private sector better. So that's for the first session. And then on the second session, we heard a lot about one of the policy instruments that is most oftenly used in engaging the private sector. Why? Because we probably want to make sure that the quality that was delivered in the private and but also in public sector was, meeting a certain standard, if you will. And one of the way of doing that is through an external quality assurance policy. We heard yesterday from Hong Kong case and from Indonesia case that the external quality assurance system that was implemented was accreditation. But of course, it's not automatically we choose to do an accreditation. You heard from the Hong Kong experience and also from Indonesia experience. It's really a journey. So the idea of making sure of the quality started with a lot more simpler things like quality assurance, CQI, TCM, and so on and so forth. And then it gradually moves into the accreditation system. And I really like what Professor Hung ended his session with a question, with some reflective questions about whether the accreditation is a means or an ends. So how is it that you're going to fuel your accreditation system? And the question is not whether or not accreditation system is best for you, but really about what is it about the accreditation system, what aspect of the accreditation system that can meet your objective, that can help you achieve what is it that you want in terms of meeting the quality standards and making sure that everybody's in your system is delivering quality services. As well as in Indonesia, Professor Adi Utarini also end the session with the question that we should ask ourselves whether the accreditation really improves clinical outcomes, whether it is improving participation of the clinician, patient satisfaction, experience, safety, and quality improvement. So this is to steer us away from the usual suspect of accreditation being an administrative burden, if you will. So we heard a lot about questions from participants yesterday that people were so tied up with the accreditation process, people were so busy in preparing accreditation system that they kind of get lost in the objective of why is it that we are doing accreditation system, right? So to keep in mind that accreditation system is there to help you meeting a standard, making sure that you delivering quality, and that's that. So it's not just something administratively that you need to do every few years in order to secure a contract from your payers, for instance. So that is why it's called external quality assurance, because you want to have an external body making sure that you're delivering a quality services. And that's one of the policy instruments in the framework of private sector engagement, particularly when you're trying to do an integration of services. And why accreditation is so popular? It's because if you remember this pyramid or the hierarchy of regulation, remember how the very basic one, the very low in the pyramid, in the hierarchy, is more informal, and as you go up the ladder, you get more structured way of regulation. Then accreditation kind of meet all those steps, if you will. So here, although accreditation is basically a command and control system, and this is something that you need to comply to if you want to operate. But it also talks about the meta regulation step, because there is an independent agency that's setting the standards and do the accreditation, and then there's the insurance agency that contracts only with those facilities that have been accredited. So that's kind of meta regulation. That's not just about the government is imposing you with one regulation, but there are other independent agency outside that trying to make sure that you follow the regulation. So this is kind of like a enforced self-regulation. And talking about the self-regulation, we heard yesterday from the case of Indonesia and also Hong Kong that the accrediting agency who are doing the assessment and actually accredited the facilities were also accredited, right? So it's not like they're just doing it because they have the standards, but they are also actually accredited to do the accreditation for other facilities. So, so they also make sure themselves that they are following what it is that is correct and proper in making sure that the facilities are meeting the accreditation standard. And this is also about market mechanism, because the people, the consumers, the users would more likely to be choosing facilities that has been accredited, in a market where there are some clinics that offer services, but it's not accredited. We probably might question the kind of services that are available, and people might not choose them. So the accreditation is also influencing, if you will, the market mechanism in making sure that the public, the informed public, will create demand for an accredited facilities. And last but not least, it's the professional engagement in the accreditation process, usually very much involved in making sure that there is a quality improvement programs that's continuously done even after the accreditation system is, completed, or even if you already been accredited in certain level. The professional within that facility will usually still applies all the continuous improvement program. So that's why accreditation is quite popular and quite probably is one of the best way to do it, even though Professor Hung yesterday mentioned that accreditation is not cheap. It's a lot of investment and it's a lot of work, right? So I hope I didn't miss anything, Professor Hung. So after that, we talk about a very interesting topics to some of you, I believe, which is the public-private partnership. And it has been distinguished from the usual outsourcing mechanism that you all also familiar with by having these defining characters of public-private partnership, which is there is a risk that is being shared and there is a long-term contract. And the long-term contract usually also entails that at the end of the contract, government will own the assets, the facility, or whatever the investment was in, and that there is a mutually agreed upon performance indicators. So these things are the defining characters that help us separate or differentiate public-private partnership with the usual outsourcing services that we usually do. And Professor Chantal talked about the typical structure of the healthcare public-private partnership, although this is not the only model of public-private partnership, because there are other common models of the public-private partnership, starting from the very, very common facility and finance model, clinical services model, and then there is a combined model, and then there is a co-location. And about the facility and finance model, which is quite popular in UK, there is the basically the private investment is making a huge investment upfront in building the facilities and manage it and operate it. And then there is a kind of a risk transfer from the government to the private sector throughout the building process, throughout the development process. This is quite popular in some countries in Europe, particularly UK, and probably it also has been adapted by some countries here in Asia. And a lot of this is usually talking about the infrastructure of a facility, right? Whereas the other models also involve some kind of services embedded in that investment. So she talked about the combined model, which is a bit more like an integrated model from the story that we heard yesterday, from typically the Al Jazeera model, the second Al Jazeera model, where it's not only about the infrastructure, but it's also about the service delivery. So if you come back to the framework that we had, and here you will have the integration in both the organizational integration, but also putting in the infrastructure and also professional integration. So this is a nice model of doing an integration that comprises both infrastructure and also service delivery. Whereas in the co-location model, this is more about the infrastructure, it's more about the making the availability of public asset being used by the private sector and delivering services to the public in one location. And this can be beneficial for the government in terms of the financial revenue, but also from services that are being provided. So there is an expand services that is available to the public. But this is not a simple thing to do. And Chantal gave us a warning that this needs the capacity of making and maintaining a contract, which is not easy. And there needs to be a very strong political will and commitment. And also there needs to be a capacity of the private sector as well. And there needs to be a transparency and a partnership relationship between the two. And then Professor Siripan talked about the other kind of integration that you can see were being enabled by the payment system that is available in the Thailand. So having some units, some primary care units being contract in the universal coverage system and also the social health insurance system to become a part of a network where you can have an integration of services vertically, so between the tertiary care, primary care, and those serving at the community level. So this is also a nice, I think it's a nice model of an integration of services as well. In Indonesia, we heard a lot from Indonesia, Malaysia, and also China yesterday about choosing another policy instrument, which is the purchasing, in order to make sure that the care is delivered in an integrated way. So the idea was, one of the cases about the strategic health purchasing being implemented in TB, and also adding pay for performance incentive in diabetes care. And this is one of the ways to making sure that the services that the government purchase or the government purchase is the right thing for the people and meeting a certain standard, meeting some certain quality performance. And it is, again, depend on the kind of purchasing mechanism that you use to buy those services. And this is moving away from the usual or traditional passive kind of purchasing. This is another example from China that I really like. Professor Shen yesterday talked about the situation in China, and I really like one of the example of having the hospice and palliative care in China being integrated and using also the purchasing and payment mechanism to enable those services in the long-term insurance care. This is also another highlight from Malaysia, using this time strategic purchasing and value-based purchasing. That is also another available tools that you can use to ensure the kind of integration that you want to do. For instance, here is using the clinical pathway in the case mix of Malaysia. And this is an example of clinical and professional mechanism in the integration that you can use. And lastly, we heard about one of the other instruments that you can use in engaging the private sector, which is the information exhortation, engagement, and social franchising. And here you hear a lot about the application of the business or the business or management models into the health sector, which is using the social marketing approach in trying to engage the people that you want to engage here, using not just the traditional 4 Ps, the product, price, promotion, but also the inserting it with publics and partnership and policy and purse strings that you can use to influence the behavior. This can be used either for the demand side, for the consumer, if you want to change the behavior, but to some extent, you can also use this to influence the behavior of your providers or your health workers or your health staff or your private facilities, if you will. And this is to address the kind of resistance that usually people have towards a certain reform or certain policy change in the system. And today, we are going to be on the last column here. We are going to hear more about how to use or utilize all those things that we heard from the first day and the second day. We want to be able to choose what kind of policy instruments will suit my objective, what kind of modalities and mechanism that is better or more effective in achieving my goals. And we are going to learn how to implement them and monitor them, and what are other things that we need to pay attention to if you want to design your integrated model in the future. So thank you for your attention and enjoy your last day in the course. Thank you.
Thank you, Shatin, again for her summary for the last day to refresh our memory. So we come to the next sessions, which is about the contracting in primary care. We will have 3 speakers in these sessions. First of all, please I would like to invite Professor Lasolo first and to talk about the contracting in primary care.
Good morning, everybody. Yes. So I would like to be the introduction presenter. So actually this session, there will be 2 case studies, one from Indonesia, one from Hong Kong, about how to contract in primary care. And I'm trying to present the introduction part of this session. Yes. Okay, so back to the framework. So we have to again to look at the framework, so we can have like memorizing all the things here, and we will go to the government policy instrument, modalities, and mechanism for integrations. And one issue is contracting. It's close to the purchasing activities, and then this is contracting in primary care. And there will be 2 case studies from Indonesia and Hong Kong. Okay, so what is the meaning of contracting? And if you look at back to the dictionary, it's very simple, hiring contractors, institution or organization from outside to produce or do something. So hiring contractors, not only human resources. Yeah. So it is like one organizations contract the other organizations. So this is like a arrangement between two organizations, because we have also some contract personnel. Yeah. We as organization contract staff individually, but this is not the case of our discussion. Ricardo Pitron and Ursula Gideon from Uruguay, I think, yes. They define contracting as a purchasing mechanism used to acquire from a specific provider specified service for an explicit quantity of a known quality at an agreed on price for a given period of time. So contract cannot be for long life. It's difficult, but should be like based on time period. Yes. So this is the contracting definition. It's long definitions, but actually maybe every day we do some contracting arrangement activities. For example, if we work together with another groups, then we have to start a contract arrangement based on this long definitions. And then also we try to look at the public and private mix. That means the key innovation in this contracting model is the separation and implementation function. So as an organization, we contract, we finance the other organization for doing something that we want to have, and we cannot have it. It's very important. Contracting usually in physical infrastructure like buildings, road, dam, electricity, and maybe real estates, but now gradually used in also in non-infrastructure program. It is not common yet, but now it's become more and more popular. And non-infrastructure can be many things, yeah. Can be training services or implementation of programs. So many health programs can be contracted. So when we talk about who are the contractors, that means we have to have like government partners as contractors, yes, and that means institution, agency, or legal entity whose activities and or business activities are in the health sector or other fields that support health development programs. For example, if you don't have any communication skill, then maybe we can contract some advertising agency, yes, to do something on how to promote a healthy. Yes. Why we contract? Yes. So one is lack of ability of public health services due to human resource problems, number and capabilities. For example, we don't have enough number of people to do immunizations, but we have the budget for doing this. We can contract immunizations to maybe NGOs, for example. And then improve accessibility or coverage, or maybe the absence of facilities or services. We don't have the facilities, but the private sector or maybe the other groups, they have it, yes. Improve efficiency, it's better to contract things, yeah. And then also improve quality of care because we don't have enough expertise on this issue. So we have to contract to organizations that specialize on this skills. For example, again, back to the communications skill, maybe promotion. Some people now is in the media, social media. Some people, some organizations, they do have very high skills in using social media, and our district health office, we don't have it. Then why we don't contract them for doing good for us? Yeah. And then also some sensitive issues like in HIV/AIDS. Yeah. We can have, that some of the HIV/AIDS patients or groups, they are in a very, very close, tight society. And it is difficult for government employees or district health office officer. They can go into this society. So to reach them, it's better to use some organization that they are used to work together with the close society, something like that. It is very sensitive issue, and there are many contractual arrangement for reaching the HIV or AIDS community. I don't want to say community, but groups there. Yeah. So what kind of services, whether also in primary care? Yes, actually, when we look at the UHC, Universal Coverage, the clinical services is very, very commonly contracted to private hospitals. But also we can have the basic health services, inpatient and outpatient, and also primary care. For example, how about surveillance? Yeah, can we contract surveillance activities, immunizations and promotions, TB prevention, and others? Yeah. And this is very, very important issue because actually when we look at back to the who are the contractors, then we have to have the NGOs or the private company, maybe for profit as well, that they are expert in this primary care activities. It's not easy. Okay. And then we can look at the benefit of contracting, encourage competitions. Okay, in price and quality, then better policy and planning development. So we can have like a more secure services. Yes, price stability, increasing equity of access, and can be directed at certain groups that are underserved. That's why some contracting activities usually is used in the remote areas. But we have also obstacle. Areas also weak in management or less interested in tendering. Also, it becomes more expensive because we have to bring in some people outside the remote areas. And the contracts are not well designed and managed due to the weak capacity of the service buyer. So the government is not used to have non-infrastructure contract. Usually government is used to have contracting for making dam or irrigations or building, but it's not so easy to have a contract in non-infrastructure. And then prices, there's also an important issue that somehow it's difficult to have estimating how the price of, say, promotion, yes, whether it's too high or too low, and that is becoming some problems in terms of preventing for legal acquisition that we make benefits to other parties, yeah, because the price is not so clear. But in the infrastructure, it's very clear. The price of, say, how many tons of cement or for steel, we can have the market price. And then interpretation of the contents of the contract also is not so easy. Yeah. And then also jealously from the local people if we bring too many other people to some regions. And then monitoring and governance capacity is still weak as well. So these are the contracting obstacles. Okay, the notes. Contracting doesn't mean privatization of health service. No, this is only a way of purchasing because we don't have enough capacity and need support from stakeholders and trust between the contractor and the agency that awarded the contract is very important. Information for independent monitoring, supportive political and legal environment is very important as well. And the government needs the capacity to design, develop tenders, manage and monitor contracts to avoid legal problems after the contract. And then also strengthen the capacity of the private sector to implement contracts is also important. And then this is the end note. Contracting is a policy tool, not the goal of public health efforts. That's very important issue. It's only a policy tool, yeah, not the goal of the public health efforts. Okay, so we go now to the case studies. The first one by Dr. Mubasir, my colleagues from Indonesia, and this is concerned with how the human resources in the remote area and how the complexity of the contracting options in some remote areas in Indonesia. So is it possible to have it, contracting system? And then the second case study in Hong Kong by Dr. Fei Chong-Fa, is the commissioner from primary healthcare in the primary healthcare office, Health Bureau, Hong Kong Special Administrative Region. Dr. Fang is there, yes, already there, yes, you can see that. So, Pak Mubasir, please, you start with the first case and then follow by Dr. Fang. Yeah. Thank you.
Thank you, Pak Laksono. Good morning, everyone. Let me introduce. My name is Mubasir Hassan Rasli. So, but I always ask my colleague to call me Pak Mub. It's only the one word. That's much easier. So my topic today is about the primary care and primary healthcare system in rural and remote area. I like to explore this because this is probably the area where not enough attention, even from Indonesia, when we try to implement health program in the remote area. So. Sorry. This one. So the focus, we are expected to discuss this, but I think for me, it is not possible to look at this only one, but we also look at the interaction between what we want to evaluate and what we have done so far in the real life about the modality and mechanism for working in the real field. So we do here, but we also think of how we can later monitor them. And this is also the what I want to focus is on the potential of contract system for primary care, primary health care, and public health surveillance. So the difference between the primary care is something that physicians have to do about diagnosing disease, and making a treatment. But primary health care is what the community need to act to prevent disease and to follow practice that good for their health. And actually, I also use the component of public health, which is the role of the government to protect the people from getting a disease. So the objective. So the objective is to see the problems that we can solve through the contracting mechanism, right, in remote area. And the second one is really exploring private sector engagement, how we do it. Right? This is again still in the form of exploring. And the third one, we are probably not discussing that much too about proposing incentive for establishing the contract system in the primary care, because in Indonesia, contracting private institution is not there. So Pak Laksono and us always try to promote government to allow us to do the private contracting for delivering, for example, immunization service at the remote area. But there is no legal support for this. So when we discuss about contracting, we still try to make sure that they will be good to be advocated for the government to agree on this. So the current situations in the, let me go first here, right? The current situations of Puskas, primary care. So this is, I try to explain, this is the community. When they got sick, when they get sick, they go to the primary care physicians, and through this, they can solve their disease problem completely when they go to the referral system, or if they are okay with the primary care system and they go back to the community. So the first problem is sometimes, or many people go to the primary physician, for example, for tuberculosis problem, for example. I like to discuss the tuberculosis issues because Indonesia is still very prevalent of tuberculosis. And sometimes I feel that it is no use if we have a good universal coverage, but tuberculosis is still high. Then by having this description, I like actually to focus why national health insurance still fail to solve the problem of TB because the community effort here is not enough. And also the primary care physician is probably not accessible enough for community to comply with the regimen, right? So when there is a dropout from the primary care physician, usually this person's tuberculosis case person usually hide in the community because they don't want to get stigmatized from the community. So dropout patient from TB is harming the community because they are there to contract the community, healthy community. And this, if there is no primary healthcare workers, there is a good community works to help them aware about the need of treating the disease completely. That is always like this. I mean, it is harmful for the community. So the public health protection for the community basically is to do the surveillance, try to get those who are undetected cases. But if the surveillance fails, this is again, I say, this is community health centers, this is a physician, this is community health center. In remote area, community health centers are very weak, you know. I tried to find the picture from Papua about the Puskesmas, but I didn't get into this. But in the online version of the PowerPoint, I might be sharing that, and then you can see the image of Puskesmas, community activities in the rural area. I will put it there. So community health center is weak. The primary healthcare worker weak because they are volunteers and difficult work. And that is then there is no good protection whoever who stay in the community because there is always harmful potential to contract them from the undetected case and the dropout case of TB, for example. So what we can identify here, there is no effective health surveillance. There is no effective awareness creation among the community by primary healthcare worker. And also, there is no special attachment of primary care physician with their communities. So the National Health Insurance only pay primary care physician because of their medical treatment. But the problems of the community here is not only the medical treatment, but also the social attitude to the patients, and also the lack of promoting behavior among the community to make everyone who needs the care should be there. Now, in our system, the disadvantaged people, the poor and the low-income people are paid by the government to get the primary care physician. So there are subsidy for working for the NIH. However, because especially in rural area and remote area, to go to, so this is from community to community health center. In remote area, there are very remote. Right? In Papua, you even have to go by walk for 2 or 3 days to come to the community health centers. So the role of community health center, if there is no community health workers, informal care provider, and the community become very worse, right? It worse. This is try to just explore this one. This is the system, public health system here. There is a district, there is a local health administration, local government administration, and district health office is also here. But from sub-district to district, that is also a long way to go. So this is a very difficult situation right now that we face in remote area. While in the national health insurance, they only contract primary care physician, and many of the community here do not go to the primary care physician. So paying the poor, the rural people for getting the national health insurance, something like not useful. And that is another program, another issues. So whether it is enough for national health insurance to pay, to contract primary care physician, if the community here, you don't go to them. This is a kind of like inefficiency. Okay. Let me back to the, I'm trying to find what are the rural area of Indonesia, right? Actually, I have the paper recently published in, someone, this is not Laksono now, but this is someone in Papua, in Ministry of Health, try to notify what is the remote area most important in Indonesia right now in terms of availability of hospital and utilization of hospital. Again, Papua and is part of Indonesia. Yeah, this year. Basically, when we discuss about the remote area, I mean around the border area and eastern part of Indonesia. Now, I'm talking especially in Papua here. Now, if you look at only number of public health center or community health center, it seems that Papua not as bad as the others, right? That's bad. But again, a picture can lie. So be careful. If we look at the real health center, how it works, that is the problem that we can see in terms of how they can perform and how can they do the primary care, primary health care, and the public health one. This is also very clear in terms of how people living in eastern part of Indonesia only the rich who can access to the care, but not, it's very inequal. Right? That is the importance of our discussion. So the Puskesmas, the primary healthcare centers, perform lower than we expect. And one of the issue is the health worker retention in remote area. And also, the Puskesmas have too many practical programs that they need to deliver in the community, but there is no good coordination system that make them able to do this. And this is also about the planning issues, about the inflexible use of money when they have money to use for their Puskesmas work. So low community health center performance should be portrayed in terms of the need of something that we should do in terms of integrating into the better system, looking for the potential organizations around the local there, and do something to bridge the needs of the population through the contracting system. Okay. The second one is also the health centers are very weak in doing the public health surveillance. This is also very difficult to acknowledge because that is not enough staff want to go to the remote area. The other one is this is again, I just saying that the case this. So national health insurance in terms of the utilization of primary care physician is not very useful in the remote area because only those who are stay around the physician availability, they can use it. But many of them living in the kampung and the village, which is far from the presence of the primary care physician there. I think this is also, I just want to make clear that probably we need to find another way rather than using national health insurance to provide to the rural area, but still probably we need to keep the system, community health center system, not the national health insurance one. Actually, today, community health center usually have 1 or 2 physicians for every community health centers. But with the introduction of national health insurance, the doctor here are contracted by the insurance. So they become like primary care physician separately from their health center job. And many of the complaints actually now, the community health centers become their staff is moving out to become primary care physician. And the non-physician staff become have something like no incentive to work because usually the money comes with the doctors. So if the doctors is not there, the program is not working well and they don't get money for themselves, the incentive for the worker. So with the introduction of national health insurance in remote area, the role of physician in the community health center is reduced, and they are more interested to do the primary care physician because they don't need to engage with the public health aspect where there is no money for it. Okay. Now, exploring contracting mechanism in integrated care. Okay. The first, before we go into the contracting system, I think we need to reorganize, to restructure our health center first, right? Traditionally, this is the head of the district, and this is a local health authority. We call it district health office. We take control of the health centers. And the district health office here use community health worker to give public health service to the community. Sometimes they have to go again through the air, through the sea, through the river, to go to the communities. This is commonly they do in this time. But I think we should move to, we should reorganize the organization, internal organization of the health system or public health system to become someone who used to be the executive manager of the program should be changed to the local district executive secretary. Because what? Because I think we don't need them to go by themselves to take care of the health sector program. But it is possibly good to, if the secretary executive of the district office, something like contract with the schools, with the workplace, community institution, you do the program in your community. So this is become, they don't need to go to the community, but community-based organization there to become the frontline officer of the public health program. And community health centers become the supporting unit. So just support what they need. With doing this, I think one way of streamlining the service become much easier because we use the community-based organization, workplace, school, community organization, grassroots organization. They can have direct delivery of the service to the community where they live. Right. This is one issue that I think to reduce the burdens of the community health workers here. Yeah, this is the story from that. Yeah. The second one, how about the private institution to be part of the contracting mechanism that we use to serve the community? This is community health centers. This is the old approach. This is the old approach. So they just go for mobile health service surveillance activities, but they only use the health sector one. But many other ministerial programs other than health is also want to go to the communities. So if we change the manager here to become village administrators that appointed by the mayor, so we are not only serve the people for their health need, but also for other social need from other ministers. So compared to if public health service, primary health care is done by the community health center, they only health sector program that can be delivered to the community. But if we change to become the the implementer, the managers of the program become the village administrators, then we can integrate many other programs into one integrated mobile service to the community. Now, to try to create a need for contracting system for integrated mobile service is actually there. But the problem is that the problem is how can the government create incentive for private institutes to invest their capacity work in rural and remote area in this advantage one, which is actually, if we want to hire private institutes, we should use or employ the local resident to be part of it. And this is again, for example, how to create a training for local residents in order to get recruited from the private institution to do the work. I think the last one about these issues is also the role of central government, how they can openly say, no, this is the time that local government should take care of their own population, and they have to work hard to do this, while the role of central government become like more facilitating or even supporting the local government strengthen. I think that is what I want to say and about this. It's again, primary care system in rural and remote area cannot be separated from the work of the primary health care and the public health system. The second one, the shortage of public health workforce is in need of other agencies should help them. That can be organized or through through buying, through the contract of the agency who can help the health center to provide the service. Yeah, this is actually, it's difficult for even for us in Indonesia to imagine everything can be solved. But again, it depends on the system at the local government there, like in Papua or East Nusa Tenggara. There's a lot of social problems and issues that cannot be easily tackled. But that, again, I think if we work hard to try to identify the problem, the challenge, we can have a better way to solve the problem there. Thank you.
Okay, thank you, Dr. Mubasir. So I think the discussion will be after Dr. Fang's presentation. So I introduce Dr. Fang. Please come here for presentations. Your time is 35 minutes, so we can allow 10 minutes for discussion after that.
Thank you so much for giving me a chance to share some Hong Kong experience. Maybe I introduce myself. I start to take up the role in last year, so I just in the post for about 12 months. This is under a blueprint we call primary healthcare blueprint in Hong Kong. So when Professor Yo invite me to share some cases, I may find difficulty because we really had a very short experience in terms of the contracting our services from my perspective. But I know in Hong Kong, we have tried a lot of models. So today I may share some of our thinking along the past 10 years, and then we come to today's what's happened in Hong Kong. And, sorry, I also see many of my colleagues here. So anything I'm telling something wrong, just stand up and point to me. Okay, today I find this model is very useful to me. I think everyone discussed this report, so it's very familiar to you because I just heard the introduction. They also mentioned this model. I think we fit a lot into this model because this is what's happening in the last 10 years. We really start our public-private partnership program by building or refurbishing the public healthcare infrastructure. We also try to add or expand service delivery capacity. Maybe I provide some background information of Hong Kong. Hong Kong, we have a dual track system. That means the public system and private system. And the public, basically, we are a hospital-oriented system, and everything comes from the hospital-based kind of service. So we have a hospital authority, which has over 90,000 staff, and also 44 hospitals, if I'm correct. For the private, we only have 13 hospitals, private hospital, but the size is small compared with public hospital. So is in Hong Kong, about 90% of inpatient actually taken care by the public system. But in the private, in the opposite is most of the primary care with attendance is basically taken care by the Western practitioners, like a private GP and also a Chinese medicine practitioner. Now we have 10,000 practitioners in Hong Kong. But they sadly say that primary care in Hong Kong is very scattered, and so there's no structure, organization, communication for the providers. So even with this kind of picture, but we're facing a problem in Hong Kong is the public system basically is very, the fee is very low. So people will rush to the public hospital system, no matter which is a mild illness or is a severe illness. So people will see doctors in the private because they feel symptoms, and doctors in the private have no idea or have no interest to treat the chronic diseases. That's because it's not profit making in terms of, because you need to look after the chronic disease with the relatively higher risk compared with just common colds. So that's the background of Hong Kong. So in Hong Kong, we have just a general picture is the 83% of our public health expenditure basically goes to hospital. 17% goes to primary care, we say is mainly provided by Department of Health as well as the general outpatient clinics of the hospital authority. Maybe I give you an idea is in Hong Kong, we in the public hospital system, we have about 500 family medicine practitioners, or some are trainees, but they're taking care of about 5 million attendances a year, while we have 6,000 specialists in the hospital system, mainly taking care of about similar number of attendances. So you can imagine in Hong Kong, we are not that focused on the primary care in the public system. So it comes to the point that we really overload with patients. So we now need to wait for patients if they have only mild problems. They may need to wait for 5 years or 3 years or 2 years in the specialist outpatient clinics, like a hip replacement. You may need to wait for 10 years before you can get a hip replacement in the public hospital system. So you can imagine how worse the situation now we encounter. And also we don't have a much idea is how we can, share the workload with private. Because private may only focus on some items they have interest. So this is one of the public-private partnership system that the hospital authority tried to deliver in the past 10 years, if I'm correctly. So you can see that this is the PowerPoint they show me, and you can see that what the picture looks like is a one direction arrow. That means our idea is how to contract our services to the private from the public to private. So you can imagine that means from the specialist clinic to primary care. So our system is very strange, is that the patient basically go to the specialist clinic first and then go to primary care in the public. So this is first. This second is we try to control a lot of things. So we centralize a lot of things. We centralize the hospital fee, the patient charge, centralize the drug supplies, centralize everything, investigations for the public-private partnership. So in that sense, the private, if you look from this project from private angle, probably you don't have a lot of interest. In that sense, is they only control everything, and they are just the kind of providers like a robot to provide the service to the patient in the community. So this probably the reason, although we have a lot of projects coming in, I think the most successful one is the PPP cataract project. I didn't put here. But this is some figure from the hospital authority in the last year, so to show how many patients basically have the PPP managed in the private. And this is HA provide me this table, so I need to thank them. If you look at the GOPD, we call General Outpatient Public-Private Partnership Co-Care, it's looking after about 53,000 people. I can just tell you there are about 1 million patients under care by general outpatient clinic. So you can imagine this size is not that big, okay, compared to in terms of sharing the workload of the system. And for the very successful one, I think is the cataract one, I didn't put here. Basically, it claims to shorten the waiting time from 10 years. Oh, CSP, this one, 5,000. Thank you, Christina. Yeah, you can see they have 5,000 cataract surgery, which has been done in the private. And they claim that it shortened the waiting time from 10 years to 1 to 2 years in the public. But basically, and it goes back to look at the program, it's very strange because every year there are more than 5,000 new cases in the eye ophthalmology clinics. Why it can shorten so much? What I can say is there are some tricks inside this in the waiting list management. So some people in the waiting list, maybe they die and they're still on the list, or because before the computer system comes in, you just by a notary kind of waiting time calculation that made the list so long in that way because people, some they have one eye done and then waiting for another eye to have cataract surgery, then they count it twice, okay? So you can imagine what's the picture looks like is we don't have a lot of coordination among the PPP program. And the size of the program may not help in with relieving the public system workload. So these are the problem. One is centralization or everything. Second is the program probably not that attractive to the private. So what now we are trying to look at is if we want to do more primary care, which is the trend to expand the healthcare continuum for the public-private partnership. If we still use this model, I think it's not that maybe we just repeat something that the attractiveness or the popularity in the private for the people to see the private doctors may not be that high. So, but we know that this is the way to go because nowadays we're a hospital-based system. We have very much little preventive care in the public, and the primary care is so uncoordinated. And also we mostly focus on immediate care. I don't worry about that, but we really worry about long-term care, okay? And we don't have a private end-of-life care. So those things are coming in to see how we can do it in another models that we try to work on. So thank you, Professor Fong Hong, and also Professor Yo. He shared with me this report, and I really enjoy reading this one because it shows how we can explore the model according to this direction. Although I started a program in November for we call chronic disease co-care program. But basically, I think every items basically fit into what we try to work on. And according to last month's figure, we think is quite successful because we started the program in the 13th of November. Now we have more than 10,000 people join the program and pair with their family doctors. So the figure is still going up, and we hope to have a more analysis so that we can figure out what's the successful factor for this program. So we come into from a centralized system to a program with decentralized service with centralized procurement. Okay, so we try to make use of this because in the last slide, I think in the previous one, the effective relationship, transparency, and the trustworthy partnership is not well addressed in the private. This is because in Hong Kong, private doctors, we are not worried so much about the private practitioners at the moment because the quality is relatively good, and also Hong Kong is very small, and we have a lot of private doctors in the private. So seems that this is not a matter unless one district in Hong Kong, that's Island District. Island District looks like remote area. So the number of doctors practicing there is not that high, and also population size is not high. So we will also encounter some remote zone issues, and also we will jump into contracting matters after we roll out the program for some times. Basically, I think contractual organization is our concern. So it goes to decentralized part. So what we try to decentralize, we decentralize to a pairing system. That means for one doctors with a family or with participants of a program, and then to see whether we can further going on into a system. So we only design the subsidies for pair doctors and participants. That means we try to show our respect to the doctors or the practitioners who are involved in the program. And this is quite critically important, because if a service provider, they just take your money and do something, it's very cool, okay? It's very cold. The relationship is very cold. They just give you a figure and they manage the patient. And also find that the previous contract out system, they don't care about the quality of the provider they provided. But if we say, okay, we try to look at their quality, basically, it seems that they are not happy, but basically they are happy, because they think that someone are looking after them. All right. So this is a paradoxical thinking. And that's why we try to think whether pair doctors with participants, that's what we call family doctor, okay, under the name of family doctors, do everything. So we try to see whether we can develop a health plan for everyone of the citizen, say, at a different age and with different gender and family risk, so that the family doctors, although they are not work for everything under subsidized scheme, but they seems to know that as a family doctor, they have a lot of things to do for the participant involved, like vaccination, cancer screening, and so on. Some of them have been subsidized, but not all of them. And so this is an empowerment concept. And then what goes to drug formulary, we're through to, HA, when they buy the drugs from the pharmaceutical companies, they will buy at a very low cost. That's about 1/10 of the price of those private doctors if they buy directly from the pharmaceutical company. So we try to use bulk price. That means that the private doctors can take a very cheap drug price from the pharmaceutical company. In that sense, it is also a kind of respect, because during the COVID pandemic, the doctors, private one, we asked them to help. But the feedback is that, you all public doctors have to all the PPE, but for a private one, we didn't have any support from the government, because they think we also work for the public to treat the COVID patients, but you didn't care about us. So we think about the community drug formulary is kind of a source of respect and benefits to them, so that they can care of some disease we focus on. And bi-directional referral to hospital authority is kind of support, because another thing we really want to build is the integration concept. That means how we can integrate the private sector. At the moment, it's still track. That means there's no relationship between public and private. Whether we can build a system we call bi-directional referral between the public and the private system. And pay for performance incentives is really important. It has been first time to incorporate in our program after Professor E.K. Yo's presentation in the Blueprint launch day. I still remember that important day, because we have some internal arguments in the public, because in the bureau, because we never try an incentive system for the private for a program. Okay, so this is something we try to start with and explore whether it will really bring up the performance of the private doctors and also the patient empowerment. So and then we try to decentralize the district health service. Previously, we start from the idea is that whether we need an center or public health center in the district, so that they can promote the public health and in the district, so that they are more close to the communities. But the problem with is if we don't have a disease concept behind the district health center, they would just do some promotion without intervention, without concept of intervention, and the community don't have some sort of connection with this center. So that's why we still need to build some sort of connection through chronic disease program to bring them up to the more medical model instead of a purely social model. In Hong Kong, we have social workers who involve a lot of primary care system. But India concept is more on environmental approach, like whether we can deal with loneliness, whether we can deal with the working environment, or whether they can deal with their family, relationship. But whether they learn the medical model from a medical side, this is some sort of issue we want to tackle. So we try to structure what is lifestyle modification through the chronic disease. And then lastly is the laboratory investigation. Laboratory basically is also a very expensive or unknown things in the private. So people, when they see a doctor try to include everything in the package to the patient. So they may charge the patient $1,000, but you don't know how much is for the investigation, how much is for the drugs, how much is for consultation. So we try to break these items out and then try to contract out to provider so that they can keep their price transparent to all the public. And then this would provide more information when the people join in the program. And then lastly, apart from this too, the eHealth app, I think I need to stress is how to coordinate all those complex systems. I think the technology is critical important. If we don't have technology behind to collect all those information, it can't be done in a coordinated approach. So probably this is the total picture, what we try to work on, although we call it family doctor system, but it basically is a primary care system. And then in future, we try to connect the providers together to see how we can do it through the technology. So how we can provide the services in different approach, I can say all involve contract concept. Family doctors, if you deal with individual, it is subsidized program. But we also deal with more than 30 institutions, private institutions, to work on how to build a family doctors. Especially now we try going into island district. Could we contract out to an institution to do that? Or how can we provide more support to institution? They can standardize things among their doctors. So family doctors is not just individual doctors. It's also some doctors who work for the medical group and hospital, okay? Non-government organization, we tender to the non-government organization to run the district health centers. So that means that the government only control the computer system, and the district health center try to develop their own community programs to the people in their community. The issue is how they can have more people to join as their members. This will be a challenge because in the last 3 years we tried the system, find that people, if they say they find nothing can be get in the district health center, they won't go there. All right, but the issue is if we don't have their consent for the data, they work with all other service providers, we cannot coordinate the service. So that means that we have to engage the community to have the people sign their consent for all the data sharing among the providers, so that this can make the service in a more coordinated approach. So this is the one reason is we try to test out with more decentralized service, but centralized family doctor system. Okay, centralized family doctor system, and see how it can go. So I just say this is a centralized and decentralized model. Okay, and then what's the next we try to buy is from nursing service. How can we buy nursing service from the private? And we never tried this before. We are going to do that. And we try the bulk service for the community drug formulary, and also we buy the laboratory service from the private through the contract. And also next time, we will try to see whether we can buy the service for mental health. Okay, for mental health. That means because in the communities, there are a lot of NGO who can deliver the mental health care in the community. Why we need to do it on our own? We need to have a contract with them so they deliver the service for our community. And then last concept is service points. That means in district health centers, can we act as a service point of another program? Okay, then this is a subcontract of another program instead of we are the buyer, we are the purchase. So you can see this is a more complex system in that sense. We are the purchaser. In the same time, we are also the providers in the community, and also we are also part of another one's subcontract. Okay, this is some system we try to build on. So maybe I illustrate a pilot scheme called Chronic Disease Co-Care Program. We try to incorporate the doctor's consultation through six subsidized consultation for diabetes and hypertension, 4 subsidized consultation for pre-diabetes, and then we have pay the doctors for $100 for the drug cost. Basically, it's cover the simple drugs for DM hypertension, and also we allow the market to have a flexibility to set their own co-payment. That means we have a reference co-payment at $150 for each doctor's consultation. And then we let the public know this is recommend reference price, and then see the doctors whether they will set their co-payment, the doctor consultation co-payment at $150 as suggested by the government. So we have incorporated some market element. We also subsidize. That means we try to control some consultation, but we will not control everything. We just mainly control what we want to look at. And then we see how this can go out in the private. This is the tender. We are going to 18 districts. That means that nowadays we have 14 NGO, non-government organizations who have bid the tender to run the health centers. And then we set the computer system for them. And then we collect the consent for every members of them. So nowadays we have 1,600,000 members, and our targets really want to achieve millions of members in the coming years. Hopefully with more, system comes in. And then we try to see bulk contract on the drugs through the hospital suppliers that can have a stable supply as well as the price that's relatively similar to the public hospitals. So that, for example, some drugs, they cost $3 in the private per drug per tablet, now just cost $0.3 in the private. So I just have, because this is some confidential for the public, and the doctors just tell me that they just need $27 for 3 months drugs to treat hypertension. So you can imagine they still can earn $30 per consultation for seeing one hypertension patient. So this is the investigation list. You can see this is co-payment. That means if you check hemoglobin A1C, at the moment, probably if you go out to private, it costs you $300. But here you just need to co-pay $20 for the investigation, and to keep transparent, and people know the price they are going to pay, and they also understand what the consultation from the doctors. So this makes things transparent, okay, to allow the people can access to this, the information. So apart from those contracting concept, we start to work on the concept of respect, okay, concept of respect. So nowadays, every member of district health center, they have family doctor's name on the card, and also next month, they are going to see their family doctors in their eHealth app. That means everyone, they download the eHealth app, and they can have their family doctors, everything inside the app, so that they can build a long-term relationship through this logo and also some virtual relationship. And you can see, if you really don't go to this family search doctor system, they know the price of each doctor. I just captured this screen is because this shows a very interesting point is these doctors, female, charge $50 co-payment, okay? And there are lots of program, government program she is going to provide it. And there are also doctors in somewhere in Tsim Sha Tsui charge the co-payment $734 for each consultation. So it depends on whether the patient wants to see him or her. So this price transparency make the people to understand how they can choose the doctors they want, and also they know what the doctor's going to provide, and also they know it's going to be their family doctors and have a long-term relationship. So it depends on their economical affordability to choose the doctors. So you can see another doctor is 300. So you can see the range is so huge. Okay, range is so huge. Another interesting point is that we try to create a personal health account. At the moment, we just start with a program like the chronic disease co-care is if the participant, they self-report their BP and sugars in the e-health system, or they try to comply with the program we offer to them. If they meet 2 out of 3 or 3 out of 4, they have extra $150 in next year. Okay, so we try to create a health account, although this amount is not much, but I think this is some sort of incentive. We try to have more patient empowerment. So they do everything for themselves from chronic disease care, chronic disease co-care, and then they can gain some benefits like a coupon in the supermarket. Okay. And another point is we provide incentive to doctors if really they provide the service to the participant they pair with achieve the A1C result or BP result, and then they will have 15% more for the subsidies consultation. Okay, so this what we call is incentive for doctors. So everything is going in place. We need the technology to capture all the information so that at the head office or in the bureau or future primary care commission, we know each transaction. We know the co-payment by each doctors. We know the number of participants they pay. We know the diabetes control, and we know whether they got the consultation according to our package, arrangement. So you can see this is a capture about laboratory investigation. We will show the package to the participant and the dollar sign in the referral letters when the participants start the screening of diabetes and also hypertension. So this is some capture I would like to show you is on the computer system. The doctors can get the reimbursement directly from the technology arrangement, and then they can have their money goes to their account directly at each month, end of each month. Another thing I just mentioned is apart from family doctor system, district health system, and then we think about whether we can have a connected services with another NGO. This will be a kind of contract to allow the service provider to come in with our system, provided they use our healthcare system. I mean the platform, so we can still capture the information. So that's so important for us. You can see is the consent of the participant. If they give us consent, they can get the subsidies. They can have us to control and coordinate the back-end things, so we can try to make sure the quality of the care can be up to what we want. And this is scheme or investigation is I won't show too much. And drug ordering, this is the one thing we try to arrange is when they order the drugs on the e-platform, I mean the doctors, they can also use the drug for other patients. So that means they can have the benefits and advantage, not only restrict to the consultation, but also can earn from the drug. And this is some sort we try to incentivize the community doctors to join us as a kind of subsidy scheme, as a family doctors being respected, and also had the support from our district health centers. And then this hope to build a network to have some sort of integrated concept. So I stop here because the program has mainly the bring home messages. We try to centralize something and then decentralize the service so that we can keep the participant closer to the service provider. But in the back end, we centralize computer system, we centralize drugs, we centralize investigation, so to have a more standardized and consistent approach. So this is the end of my presentation. Thank you so much.
Thank you. Thank you, Dr. Fang. So I think we have still time for discussion. Please, Pak Mubashir, come here. And Dr. Fang, can you So it is very interesting that it seems that contracting is easy to be discussed, but it is not easy to be implemented. And we have the tradition of infrastructure contracting, but when we go to the program contracts, it's not easy. Okay, no, so we have still 15 minutes for discussion. So please, if anyone, 2, 3, yeah. So for Indonesia now.
Yep.
Oh, yes.
Yeah.
Yes, you, yes.
Thank you. Thank you for the very interesting explanation, Dr. Fang. I wonder, could you please share what is the district health center look like? I mean, who are the staff working there and what kind of services that provided? Is it like the community surveillance, or do you also have services for pregnant mothers or like newborns, etc.? Thank you.
Thank you very much. This is really good question. District Health Center at the moment is funded by the government, and they can employ, say, roughly, is because different NGO, they provide different number of staff ratio, maybe 15 nurses and also some social workers, and also the assistant, and also we have physiotherapists, occupational therapists, pharmacists, and so they are the professional work as a team. Your question is really good, is the how we can deal with the health plan. At the moment, we try to put the chronic disease at first item to drive, and then second would be women health, and the elderly health, because we need to reduce the duplication for the service provided by the Department of Health at the moment. So they will migrate the women health service to us, and we can start to see how we can work together with, the community center in terms of the women health. But it's not talking about antenatal, because for antenatal service, we will migrate to hospital authority as a one line or so-called streamlined services for pregnant lady. But for family planning and for the postnatal care, we are going to think about that and see how we can integrate into the district health center, and then with support of the public health system. And this is a plan we're going to do, but thanks, this is really good question. We really need to work on. Yeah. Yeah.
Doing the evaluation of the district health center for the government. The district health center, because in Hong Kong, that's why we talk about integration. The horizontal integration is equally important than the vertical. Like from the same thing in Indonesia, because there are multiple providers. In Hong Kong, we have very good maternal child health clinic. That's why our maternal mortality is practically 0. And then our neonate mortality is below 1. So we have excellent medical and maternal child health services run by the government. So they're clinics. We have a lot of elderly health clinics run by the Department of Health. We also have primary care clinics run by the Hospital Authority. And then we have PPP programs on vouchers, which the government is purchasing from the private sector for elderly people like myself. So we have multiple programs, public and private, for primary care. And they're a whole range of preventive, curative, and rehabilitative, right? So there are all these programs. And the district health center was set up 4 years ago by the previous chief executive, because she thought that it was important, because the health promotion part, the connection to the community was not there. So she put that in. Originally, the district health center had some concept of district health system, right? So your health system is quite different. It's like having the whole primary care integrated, but because it was too ambitious. So the main thing there was they're doing a lot of health promotion programs. They're connecting to the connected to the community, getting them to go there for health assessments, right? To health assessment for risk for diabetes, hypertension. And once they have got these factors, they refer them to a GP for diagnosis, screening for diabetes and hypertension. And then after that, they have treatment. So now government is revisiting the whole thing. So we have all these programs, and Dr. Pang's job is to get this thing to work better. So he's starting with the core care scheme, and the other side would be then because the NGOs running the district health centers many of them are social, on the social side. So they're not medical people, right? So they don't understand, they don't have the medical backgrounds. So in fact, in future, the district health system, I think I don't want to preempt you, the district health centers will be more the connector. So they're connecting the community to the health system. So that and then that Dr. Pang is looking at all the total resources and how to integrate that and gradually mobilize the resources and redefine that. So it's a quite interesting exercise. So you should come back again and see how we've done next time.
Okay, thank you. So the second question.
Thank you. Interesting presentation, Dr. Pang. I would like to ask on maybe you could elaborate more on the TCM. Because you have the TCM primary care and TCM hospital. So what are these two positions in the health system, and how people can choose? Is it by their own preference, or you have your other mechanism? And is there any also possibility East meet West? So how could they interact each other? And the second one is the connected services, because you mentioned that you also give the opportunity for the NGO to work with. So how to do this? Are they applied to the district health office or other mechanism, and how to monitor, and what type of subsidies that being given? Thank you.
So I asked Pak Mubasir about this. Yeah, how about how to combine with the traditional medicine that you mentioned as well, the informal? Well, I think it's first. Yeah. Okay. This is also similar problem with Indonesian case, I think. Yeah.
Thank you. This is also excellent question. I think this is something we need to explore. At the moment, Hong Kong, the TCM and the Western doctor system are totally separated. And basically, TCM mainly, I think they have their own clinics and they have some subsidized clinics. Like every year, we have 18 government subsidized clinics in Hong Kong, Chinese medicine clinic or traditional medicine clinics. And they nowadays we subsidize about 800,000 attendances a year. So the people, if I'm correct, they just pay say $120 for each consultation, include 3 days herbs. And also there's some subsidized, I think, the acupuncture or some other maneuvers. The issue is we are still discussing how we can have more integration. Like the day before, we're now talking about whether the Western, the traditional Chinese medicine practitioner can order X-ray or laboratory investigation, some sort of things like that. But I know it's still a long way to go because the evidence concept is different in the two health system. But we think at the district level, what I'm thinking is, firstly, we now develop a so-called sub-directory, primary care sub-directory. So the Chinese medicine practitioners, they can register as in the sub-directory as primary care providers. And then in future, we are thinking about whether we can have a computer-based connected system with Western doctors in the district, so that they know the information from each other first and share the data first. I think this needs the consent of the patient. So this would be the first step we are going to work on. And the second thing is when we talking about how to. Sorry, the second question is the mental health. Yeah, because in mental health, I think it's quite specialized area. Some NGO, non-government organizations, they adopt two models. One model is here from UK. They use well mental health practitioners. That means there's some psychologists, graduates from the university, they have some training and deal with mild symptoms of depression and anxiety. So the result in the UK showed that it's very cost effective. So we now try to contract with them to see whether they can provide service at a very cost effective approach. Second model we are testing out is the GP model. Now we see whether we can use subsidies program like this, and then see whether they can deal with some disease like more severe depressive symptoms. For the moment, we have another program which connect with the hospital. We call ICCMW, which as actually the psychiatric nurse can see the patient who need the psychiatric intervention and then directly refer to the hospital for management. So we can see how we can build the first layer of primary care so that they can identify the serious problem and then connect with the services in the existing providers. And this is the approach we try to work on. Thank you.
Regarding informal care providers in Indonesia, which is not registered by the Ministry of Health or District Health Office, I think the way we have to deal with this is try to invite them or try to provide a platform that they can register in the District Health Office. At least if they are registered, then we can mobilize them to do something like a surveillance, but individual surveillance to check or do screening whoever come to them and make a reporting at least to the primary care physician or to the primary care center. So this individual can be followed up in terms of if they have something seriously need for their treatment. So the registration for the informal care provider is just important. But usually, this informal care provider is usually not the training-based one. So so this is another legal issues that we might think of whether we really want them to be part of the system or they need to be banned because there are no control whatsoever from their association or from similar organizations.
Okay, thank you. So there's time one more. Yes, one more.
Yeah, sorry. Thank you so much for the opportunity, Prof. Laksono. I want to ask first for Dr. Mubasir because we are from Indonesia. I think it's very good discussion if we can see what Hong Kong already do for the primary care. And it is very interesting because I'm also from health office, actually from Jakarta. And I see that the family medicine is running very well in Hong Kong. And how about in Indonesia? Maybe Prof. Laksono and also Dr. Mubasir and all of the lecturers from and also the expert from University of Gadjah Mada can forward this learning into our Ministry of Health, especially, and also in Jakarta because we are the capital. But then next year we will not be capital anymore. Because it's moving to Kalimantan and we are going to be global city then. And of course, it is very good learning for us to see Hong Kong, and maybe someday I will bring this learning to my head of health office in Jakarta, that we will learn into Hong Kong like Prof say before. And I see that maybe Dr. Mubasir or Prof Laksono can explain more what is actually the expectation of family medicine in Jakarta. I think we already tried to run for this, but it's not really good running well, not really running well. And it's especially because of the fee for services, fee for the primary care is not really good in Indonesia. And that's why I need to, Dr. Fang also maybe explain how about the fee between primary care doctor and the specialist. And I think the position of primary care between primary care and specialist, is it the same level, not like in Indonesia, because we are our study system make it into like a milestone between primary care doctor and then become specialist. So that's why primary care doctors like a second line. And I did research before. Most of graduate doctor, fresh graduate, do not want to continue to study, do not want to work in primary care. Why? Because the salary is very low. That's why. That's the big problem actually. And I don't know in Hong Kong, maybe good also not really far from specialist and primary care. That's why I say. And then how about the roles of professional organization in Hong Kong? Is it really good collaboration between organization and the government? Thank you.
Okay, one question first, and then
Yes, I think this is also reflected very much with the urban setting system, which is in Hong Kong, and how we deal with the multiple urban, rural, village, and community, which is very wide area that we have to cover. Then whatever we want to discuss now about the type of service that we want to provide in urban setting and the rural setting is very different. So for rural, in terms of rural discussions, for family medicine or family doctors, probably is luxury still. So from my perspective, if even we are trying to push how nurses can be part of the primary care providers in the community or at the sub-district level. But if we are thinking about the family medicine doctors, I think that is always only possible if we are discussing in the setting, an urban setting level, or a very modern urban setting in Indonesia, like in Jakarta, where the families have the need to do that. So, but in terms of the rural populations or smaller cities, they don't really care about who's doing what in terms of family medicine or primary care, general practitioners, things like that.
so family medicine specialist is more in Jakarta than in Papua. Is still luxurious in Papua. Okay, Dr. Wang.
Thank you so much. Hong Kong, I think due to historical reason, we share the same problem basically. Yeah, but the issue is in 20 years ago, wheelchair, am I right? Family Physician College. We have an Academy of Medicine. One of the specialist colleges called College of Family Physicians. And they start the development 20, 30 years ago. And then nowadays, if you ask me, we try to develop the system at the moment, 30 years ago, it's not possible. But now the family doctors the family medicine become more and more popular because I think in the public system, the salary is the same, no matter you practice a family medicine or surgeon. But in the private is a huge sky difference. The surgeon can earn $1 million a week, and the family physician maybe a few thousand a week. But the issue is in the past 30 years, too many surgeons basically go into private markets. I think the issue is the private market has their own way of doing living. So nowadays, I know more graduates prefer family medicine more and more because as I left the hospital authority a few years ago as the head of HR, I know that many graduates prefer to choose family medicine as their first choice. So with more and more graduates in Hong Kong, I believe more doctors were willing to practice of GP. The issue in Hong Kong is the training for GP is too complicated. I think as a family doctors, especially for the prevention, the general doctors with some family medicine training is enough. The issue is how we can deal with more complicated case. Maybe we need to set 2 tiers of GP system in Hong Kong. This is something we are thinking about. But the issue is the doctors. We hope apart from the doctors alone, we also need nurses. We also need the allied health to support them because at the moment, I don't think solo practice is a good way to do things. So recently, we have also changed tried to amend the ordinance for PT physiotherapists. They still had the thinking of solo practice at the moment. So in Hong Kong, we have the similar problem. Everyone want to do solo instead of in teamwork. So that would be a great challenge. And irrespective of salary at the moment, basically they want to do solo and earn money on their own. And this is something we want to deal with. Yeah.
Yes, and the Hong Kong Medical Association working very well. The Hong Kong Medical Association, the GP Association.
I think we still the medical association to me now becomes doctors association, we can say. we work a lot with them by understand each other instead of they would. I think they didn't, they didn't resist or they basically support our approach. Yeah, support the program. But in longer term, we still see how's their view because we try to make prices transparent and then to make the investigation more affordable to people. But to them, probably I mainly challenge them in moral perspective. Is for the time being, less GP practice to work for chronic disease, and this is something they really lack of. And so at the moment, we try to challenge them from moral approach, whether it's a role of the general practitioner to do more on the preventive care, yeah, step by step, ethically.
Okay, I think Ibu Irma, I think this is very important issue that Jakarta is not the capital again, but the same as Hong Kong, the capital is in Beijing. Is that right? Yeah. But it's still global city as well. So you have to learn from Hong Kong, and Jakarta is only 5 hours flying. It's easy to be here. And then next year, I hope that Dr. Professor Chang from Fudang University will join us for the Chinese, the mainland China. You have many urban and rural as well. And then we can also comes to China for studying how the rural health in China. Is that right, Professor Chang? Yes.
Yeah, welcome all that's network and that's member institution, but also other Asian Pacific. And I think in China is much diverse. I think the whatever east, middle, and west part actually have a lot of differences, but also urban and the rural have yeah, and there's some gaps. But we have the urban and also the rural area and have a lot of experiences and just improving much, but I still have a lot of work to do, and welcoming you to Shanghai, to China, and also to explore those kind of health delivery system and whatever public and private, and also different level, how they work together, but also to have more understanding about why in China and the public system is more dominantly, and but I think private, and we also need private sector engagement, and welcome.
Okay. Okay, thank you very much. Okay, because the time is up, I've been warned many times, so thank you very much for Dr. Fang and Pak Mubasir. Hands, and again, we have to leave now, but I hope we can meet again in the next future. Thank you very much. Okay.
Thank you. Please, maybe you stay here. We'll take a photo with you together. Thank you very much for these insightful discussions. So we come to the tea time now. We'll have the tea until the 11:30, and then we'll have the last sessions in the morning about the implementation, monitoring, and evaluations. We'll have some snack and coffee at the back of this room, so please enjoy.
Bapak Ibu, kita akan break 15 menit. Jadi silakan Bapak Ibu jika ingin ke toilet dulu, namun kalau boleh jangan leave Zoom ya. Terima kasih.
Recording stopped.
Lê Vũ Thái. Buổi
Bapak Ibu, beberapa saat lagi kita akan mulai. Jadi jika sedang ada di luar mungkin bisa kembali ke depan laptopnya. Terima kasih. Bapak Ibu, saya baru dapat informasi dari Pak Mup. Materi Bapak Ibu, mohon maaf maksudnya hasil latihan Bapak Ibu yang kemarin sudah dibuat masing-masing kelompok mungkin bisa disampaikan di dalam WhatsApp grup. Jadi disampaikan dari hasil identifikasi berkelompok kemarin, tantangan apa yang ditemukan, lalu strategi apa yang perlu dilakukan gitu. Mungkin perwakilan kelompok saja menyampaikannya melalui WhatsApp grup. Nanti Pak Mup akan mengajak diskusi bersama juga di WhatsApp grup gitu. Silakan mungkin perwakilan kelompok bisa menyampaikan di WhatsApp grup apa yang tantangan ditemukan, lalu strategi apa yang dibutuhkan dari tantangan itu. Terima kasih.
terms
Recording
of
in
design
progress.
all our health system interventions are all complex. There are multiple things involved. You don't have one simple solution, right? So the things are so complex, then we need to understand what is it, the basis of what we're doing, and then whether the solution is right or not, and how you implement the solution, right? So there are many steps in, and that's why there are so many problems all over the world. It's not just unique to Indonesia or Thailand or Hong Kong, but even globally. So that's why I'm interested in looking at how to design the systems. And I'll take you through this so to learn what you shouldn't do. This is what Hong Kong did, right? And it demonstrates all those four problems. We have this elderly health voucher, which is done before Dr. Pang's time. So I'm at liberty to talk about it because I did the research on this one. So I do not, because it's not government funded research, so I can say whatever I wish because this evaluation has been published, right? And I presented to the government before. The elderly health voucher was a very interesting scheme that government decided in 2009 as a pilot to give each person that's over 65 in Hong Kong a $200 voucher, right? So you could spend to see a doctor, a private doctor, anytime. And that scheme was originally to supplement public health services because they wanted to decrease the load and provide financial incentive to choose their private doctors. Wanted to encourage them to choose a doctor, is what Dr. Pang is trying to do as well. A closer relationship. And then they also wanted them to use it for preventive care, right? So this was the ideas were good, right? But the problem definition really wasn't clearly defined what the problem was. Why should you give people money, a voucher? Because Hong Kong, we love vouchers. You see, one of the problems in healthcare is that because I teach policy, there's this model of healthcare called garbage can model, right? The garbage can model of healthcare in policy is that in this garbage can depends on what goes into the garbage can, what is in the garbage can. So there are problems, solutions. So the problems and solutions are mixed. And people, just because there's this solution, they use the solution for a wrong problem, right? So it's because that's what happens very often in policy. We look at the things that are done. Oh, we like to have this voucher scheme because vouchers are a demand side tool, right? So demand side because you want people to use the services. That's why you give people the choice. So when we have that money, we can either do a supply side or a demand side. So we can either provide, like what we're trying to do now, we contract, that's the supply side. So we want to improve care, we could have contracted, but the government decided to do demand side. But what was the basis of that, right? And when you look at a voucher, if there are no limits to what you do, you just spend it for whatever. So like Hong Kong, we now, for each one of us, there's also this because we love vouchers. So the financial secretary last year gave each Hong Kong citizen $5,000 on a consumer voucher. So you could spend it for whatever you like. So it's very nice. So some people use to supplement their travels. Some people then use it for healthcare. A lot of people then use it to go out for restaurants, entertainment. So it was very nice because this was done because of the economy was very slow and because of COVID. So the government wanted to decide to stimulate. And that's what vouchers do. They give people a choice. You use it whatever you wish. But should you be using it for this elderly voucher, right? I'll show you some data. So they increase it to 3,023 now. So each one of us is now given $2,500 a year. So I have this. I'm already in my 70s, right? So you have this voucher. It's very good for the older person. You have 2,500. You can use it for any primary care doctor or the primary care practitioners in the whole system. No limits, and they don't even. So you can use your voucher, and then you go to see a doctor. You register, and because Hong Kong everyone has an ID, so it's very simple. So everyone, you just tell the doctor your ID number. They will then check your account, give you a choice. Then the doctor, after seeing you, can deduct from the voucher, the amount. So it's a very simple electronic mechanism. But the problem is, of course, you don't know whether the patient has been seen. So once I see a doctor, so the doctor will deduct from my account the amount of money and claim that from the government. But how does the system know that the doctor is charging me things that I don't know, because they can deduct any amount from that. So the patients are given a choice that you can either have a co-payment, because government estimated it's $250 per person per visit. Like Dr. Pang was saying, they estimate $250, but the co-payments are not defined. So the doctor can charge any co-payment as long as the patient will pay, right? Or the patient can decide, if a doctor says that you come for me for this consultation, charge $500, you can deduct all $500 from the voucher, right? So what do you think patients would do, right? They will just have it deducted. They're not going to code the payments. So you have a problem in terms of you might in fact increase the costs. Well, there's incentive for people to increase the charges because the money is there. So why should I charge more? And why should I bother if I'm a patient? You just charge it. I'm not paying for it. A third party is paying for it. The government is paying for this, right? So you can imagine the design of it is quite problematic. And why do you use a voucher? Right? Why do you use a voucher to promote this? I'll show you the data. So this is what's done. But finally in 2023, they decided to do something about, because I did the report and told them the problem. So they're now revamping some of this stuff. So I already talked about this. This, you see the amount of money that's being spent. And I haven't updated this figure. The figure now is over $4 billion. 4 billion Hong Kong dollars for this program, all right? And these are the claims. I just quickly, the first one is medical doctors. So you see the medical doctors' claims, mainly medical doctors, Chinese medical doctors, and then optometrists. And in between, you have nurses, because they are supposed to attend health primary care practices that they can go to. The physiotherapists, occupational therapists, the diagnostic radiology, and the nurses, right? So they're all supposed to be primary care. You can go to anyone, but you can see very few people go to them, right? So when we did because we did quite a few studies, we did focus groups of the practitioners. We did surveys of the patients. We linked up the data, and when we asked the practitioners and asked the patients, they didn't know what primary care was, and they didn't know what nurses did in primary care. So obviously there was a problem. And Dr. Pang also mentioned physiotherapists in Hong Kong require a referral. So they're not primary care practitioners. How can patients go to them? And so government has designed these programs when they don't even recognize that physiotherapists in our system are not primary care practitioners. Right? That's why you don't have anyone going there, right? And when you look at the voucher claims, the red one is that they go for episodic care. The purple one is for preventive. So very few people use for preventive. And then the orange is rehabilitation. And the green is for chronic disease. See, our problem with elderly people, as we demonstrated before, is chronic disease. It's not episodic care, right? So in fact, that's the problem definition is already wrong, right? So if you wanted government to really address the problem in the health system, you should be targeting chronic disease, not giving people a free-for-all. So even you have the wrong problem, the wrong solution, and then using the wrong tool, right? So this is the same thing, the claims. And then we also had optometrists. And optometrists, you know what was happening? They were telling because it's given to everyone in Hong Kong, no means tested. So many of the older people they went for eye tests. And then because the claims also you could buy spectacles. So the optometrists were promoting brand spectacles, and that's the claims went up. So because there was no limit to the claims, so people were buying Prada and Christian Dior or whatever frames and charging to the voucher, and then government then suddenly signed the rest of it and put the limit. So I want you to look at this. The blue bars are people that go only to the both public and private doctors. So the red bar is people, when we did a survey, we asked the patients, in the last month, do you go just to the public or to the private or both? You can see the red bars are people who go to the public. So before and using the voucher, the number is the same. And the green are the people that go only to the private. And you see that the percentage are about the same. So it meant that people practice didn't, but more importantly, when you ask the people that use the vouchers, you can see the duplication, the people that use both public and private, right? So what the voucher has done is encourage people to go to both the private, continue to go to the public, right? So so you get duplication of care, right? No continuity, and it's done nothing for the system. So we asked the patients, because we did surveys of the patients, and we asked them for permission to get the data from the hospital authority for outpatient attendance and for A&E admission, A&E attendances. You can see the comparison between people who didn't use the vouchers and people who use the vouchers is the same. So it had completely no effect on the public system. What it had done, it encouraged people to use the private sector, which is good for the private doctors, and encouraged doctor shopping, encouraged very few to other primary care, did nothing for the system, right? And mainly for episodic care. So for some patients, it's very good because our public systems are quite underprovided, like in many countries in the world. So it gives people an additional choice. But that should not be the main focus of a voucher. And when we, in fact, when you send this for publication, the reviewers ask, so if that's a problem, why didn't government, why don't you all provide the care yourself? Because we looked at the amount. At that time, the total amount for the voucher was about $3 billion. And the total amount for the public sector outpatient primary care is $3 billion. So you could quite easily have used that money to double your public sector outpatient care, right? And now it's gone to $4 billion, right? So it's much more money that the hospital authority is spending on your whole primary care and your family care clinics, right? So you see the problem. So when you look at voucher, it's a consumer-led demand-side financing tool, more effective, only targeted for a group for a specific purpose, well-defined, time-limited in those services that are underutilized. So it's been used mainly in developing countries for reproductive health. That's where it's worked most, because many people in developing countries, they want to encourage people to reproduce. So it's very effective for that, because you encourage people to use those services, but it must be very well time defined. So it's even if you want to do it, it's a wrong instrument. So you see the problems. Of course, the first you have a problem of the problem definition, the design of the program, the implementation, and the evaluation. In fact, we did our evaluation is done in 2 stages. We did the evaluation early on, where we already told them some of the problems. The government decided to do it. They just ignored our research at that time, carried the initial studies, and they just paid. So very problem that evaluation, how you evaluate the program is very important, right? Because you need to understand what the problems are, and then what issues there are. And of course, even if it's the right program, how you can sustain it, the continuing improvements of the programs. Right? So that's why I want to emphasize the need for implementation planning, right? So you need, because it's not just when evaluation, Maya will talk to you about evaluation. You can do evaluation formative, you can evaluation after the fact, right? So obviously, if you want to improve the programs, you need to start early. But more importantly, you can, if you plan your implementation, then you start even before you do the evaluation. So if you do your implementation planning early, you understand the problems, then you design your implementation strategy, right? But many governments do not do that. I mean, they have an implementation plan, but it's more a logistic plan, right? So you don't understand the problems in terms of design. So you need if you want to do a program well, first you need to identify what the problem is, the frame of the problem, look at your solutions, then planning your implementation, right? And then doing the evaluation. So the methods have foundation science, and it's critical for implementation strategy. And then it also helps you develop the criteria and methods for monitoring the evaluation of the outcomes. So in implementation science, we talk about two outcomes. One is the outcomes of the intervention. So it's like a program, a voucher. And the second is the outcomes of the implementation, right? So the implementation process, because so even if you find that you have an effective, like using for clinical trials, an efficacious treatment, right? So clinical trials, you do it, but then when you put into practice, you have a lot of problems of implementation. So it's the effectiveness. So implementation outcomes, you study the reasons for the effectiveness. That's why we call them the implementation outcomes. So you distinguish between what you're trying to do, looking at the variables in implementation and the variables that will lead to the results. So this is the concept. Could a program work? Does a program work? Making a program work. So you have the efficacy studies in terms of does a program work, and effectiveness for making a program work. Of course, the steps, of course, here is for clinicians: exploration, adaptation, implementation, monitoring, and evaluation, for it to be sustainable. Right? So you have these four steps. So it's quite important, because if you don't do evaluation properly, you don't even know what you don't know. Right? So if government doesn't, because very often when government does evaluation, in my experience here, it's really done just to make sure that they're not criticize the system doesn't work. So very often it's looking at patient satisfaction or the sexual using. Obviously, people are happy to do that, but it's not an evaluation tool. So when you do your evaluation, you need to know what the objectives are, right? And if your objectives of the program are wrong, then you say that you've done something very well, but for the wrong reason, for the wrong purpose. So it's a waste of time and effort. So process is important, because all of you are in healthcare. We are dealing with complex human systems. As you already heard before, human beings, when you're trying to change things, it's difficult enough to change one person, let alone change the system. We're so ingrained and entrenched. So really understand the process. So in implementation science, I just give this your ideas. I won't go into detail, right? Because there are the process models, there are theories and frameworks. But importantly, you apply the frameworks. It helps you to contextualize. So it's important because it guides your implementation planning. So you don't need to take all of this. Because you're not research. But of course, if you have a very rigorous, then it's quite good, because you really then understand how you can apply it for your own planning, whatever project you're going to in future. You specify the process implementation, facilitate identification of what determines success or failure of your implementation. And then it helps you frame the evaluation, and then for you to collect the data analysis, and then have the conceptual clarity. So this is quite a good model. It's a logic model, because many of the things that we're doing in healthcare is based on some hypothesis. So a logic model is quite good for you to put down what you think are the assumptions, right? At least you force you to think, why am I doing? What's the basis for my assumptions? So this implemented logic model is a tool that helps you plan. They look at the determinants, and then from determinants in terms of what is going to determine the success or failure of the implementation of hopefully the right intervention. What are the strategies? And then what are the outcomes, right? So in the process, you're looking at barriers and facilitators. So we want to do like in the primary care blueprint. If we want to do the implementation of the program with the doctors, then you need to ask them, what are the barriers and facilitators? What is it that why you could do surveys or focus groups, right? So probably in a lot of these qualitative studies, you can either do a qualitative interview first, focus groups, then determine the surveys, right? They identify what the barrier facilitators for this process. So this is quite useful because that framework gives you the idea. But the most often one that we use is the so-called consolidated framework for implementation research, because it's saying that there are 5 domains. All right, these are the 5 things you need to look at when you want to implement something. All right, the people that you deal with, very obvious. The intervention itself, right? Because people understand, maybe like so when you for the co-care scheme, is that the intervention, is that going to have an effect in terms of the implementation? So that the intervention itself, because it's also people's understanding of that intervention. The inner setting is in the setting where it's going to work. Is it going to work in a clinic? Is it going to work in a group practice? Is that program going to work like Dr. Peng was talking about? Now he's trying to get all the doctors in Hong Kong to be involved, but the settings are different. Because some doctors work alone, some work in the city, some work in the urban areas. Like in Indonesia, it's even more diverse. So the settings where you implement the policy is going to be very different. Like you have such a decentralized system. Your design system will depend on the program, how it's run, the outer setting, which is the things beyond it. Of course, in India, you have that big problem because your programs are decentralized, and each of your districts are very different, right? So you need to look at that, and then the process. So these are the major determinants of what you look at. Right? Obviously, then you can choose the things that you look at. Right? So there are these constructs of the outer setting domains, the local conditions, partnerships, policies, and laws. So I won't go into detail, but these are all things that are in the program. The financing, external pressures, then the structural characteristics I mentioned already, the physical infrastructure, work infrastructure, relational connectiveness, communication, and then in the inner setting, the communications, the culture, the compatibility with the culture, whether it's a priority for them to do it or not, the mission alignment, incentive schemes. So you have these things that are outside that setting that are doing it, things within the setting, which are important. The resources available, the funding, the space, because each one might be different. So especially if you're doing your program in Indonesia, the funding might be very different from each locality. The equipment, access to knowledge and information. And for individuals where you are, the opinion leaders, what are the facilitators, the team members, and then the support systems, the capability, and then intervention itself, the source, the adaptability. So when you look at it, because when you have a program and you're trying to implement it in all the different localities, how much of it can be adapted? How much of it do you want to conserve, right? Because you know that it's not going to be done in the same way for every place. So you need to look at how that intervention is, and then what are the flexibility, because that will affect your outcomes, isn't it? So the process is something that when you actually do it, how do you actually tailor the teams, essentially the context, how do you plan and tailor the strategies, right? So the engagement of people, doing, reflecting, evaluating, and adapting. So this gives you a framework in terms of if you want to do it in future, looking at first the different domains, looking at a setting, then you decide, then after having looked at all those, then you see what your implementation strategies are going to be done. So because in implementation science, a lot of frameworks and a lot of theories, but the main ones, because in fact we just ran a course a month ago with a professor from Sweden on implementation. So he was very good presenting the different types of frameworks that you can use, and depending on what you're trying to do. So having looked at the problems, you want to do a strategy. So this ERIC design permits you then to look at, it's a compilation of 73 strategies into domains, where you can then map out the things that you want to do and then how to deal with it. So dealing with the problem of, so first part is identifying the implementation issues. The second is developing a strategy, right? So you can match. I don't think you need to go into detail, but these are the tools that are available. for you to identify the problems, then also develop your strategy. And then because you've got so many strategies, right? So how do you decide which strategies? You can either do it yourself, or the other thing that they do is to do a Delphi. I don't know whether you're experienced in doing Delphi. So Delphi are quite useful because you get a group of experts and you give them some Delphi statements and then rank it. So they can rank it in terms of the importance. So if they've got people who have got the background, so you say that we've identified these implementation problems, these are the 20 strategies. Which are the ones we should prioritize? Because you can't deal with all of them, right? So if you've got people that are knowledgeable of these areas, then you can do a Delphi to decide which are the priorities. The Delphi, I don't know whether you have a lot of experience. The Delphi is quite a useful tool in policies because very often you don't have all that knowledge. So for the knowledge event I did present for how to improve our preparedness and response plan to pandemics, we accumulate all the data. Then we got a group of experts to really rate the statements in terms of importance, feasibility, and clarity, right? So that helps you also because it's not just yourself. It's really a group of people who have got that background. Of course, it's important to make sure that you've got the right people, all right? And that they can, the Delphi process itself needs to be quite, there's a guidance in terms of that they need to be able to rate it independently so they're not influenced by other people. But you also need to have discussion. So there are different types of Delphi. Right? So then you need to look at monitoring, evaluating the outcomes, right? So it's important then because it's the implementation outcomes. So the implementation, I put the different outcomes. Implementation outcomes are the acceptability, adoption, appropriateness, feasibility, fidelity, penetration, and sustainability. Obviously, you're not going to do all of this, but it's important in terms of looking at the fidelity. Fidelity means how strictly is the program followed, right? So that's why we talked about the adaptation. So if people are not applying it, as they're doing it, but they're not doing it in the way that you think it should be done. So that's how much of it can be adapted. And then, so you need to address some of these issues to see which are the important ones, not all of them. Certainly fidelity is important, feasibility, how feasible it is. So these are the so-called outcomes. It will affect the actual implementation because it's not feasible. So you just have a program there. If it's not feasible, it's not going to happen, right? So then, of course, the other outcome we're interested in is the integrated outcomes. So when we do this program, is it actually providing comprehensive care, continuity of care, but how do you measure that? And ultimately, it's the health outcomes. So you see, the evaluation can be looking at different types of outcomes, but if you're interested in implementation, you need to build in your monitoring and your data to collect. That's why when you look at these outcomes, you need to look at what you're going to monitor and what type of data you're going to collect, right? So you need to plan that early on, right? So if you really want to look at integration, because we're interested to look at comprehensive care or continuity of care, how do you actually measure that, right? Yep, I think this is my last one, I think. Yeah, yep. So here you have the how to integrate these policy and programs, the interventions for integration, and then the implementation problems is how to implement integration, policy programs, interventions for integration, right? So that's the implementation process. Okay, that's these are some of the references. I've managed quite well. Okay. Anyway, that my
one.
Okay, thank you, Ike. How are we doing today? Good? Okay. Professor Ike gave you a lot of stuff. I apologize, I'm going to give you more. Okay, this is where we are. Implementation and monitoring. I'm going to spend a little more time on the monitoring bit. There are two terms I want you to think about while we're looking at monitoring. The first is systems. For the last 3 days, we've been talking about systems. And I think one of the things that we always remember about systems, it's they're interactive. Systems have a life of their own. And I think that's one of the things that Ike was explaining, that when you do something, things happen, you don't necessarily get what you expect. Okay. The second term I want you to think about is causal mechanisms. There's a lot of the implementation science that Professor Ike was talking about. Boils down to, do we truly understand the root cause? What is our theory of implementation? Why do we think the policy that we decided on will work? Because if we are not clear why we think it will work, then we cannot monitor it. Okay. So the garbage can model that he said, we do it a lot. We see a country do something and they're successful and we go, we're gonna do that too. Without asking the question of why it worked for their country and whether those same conditions exist in our country. Because if they don't, that it worked there doesn't mean it will work in our country. So that's the important term I think we need to remember. First, this is a system, so it's interactive. And second, we must truly understand the causal mechanisms. Okay, so I introduced this yesterday, that really the framework we're using is a planning system. Okay. We're talking about monitoring, but one of the things I hope you get now is that if we're going to implement well and monitor well, it is really dependent on our understanding of the system and the current situation and what actually is pinning down the current equilibrium of behavior, which means the assessment is critical. If we don't do our assessment well, there is no way we can plan well, and it's even more impossible to monitor well. So being able to do all of that assessment well is actually the anchor for all of our monitoring. So I think when Ike was presenting, you notice he said you have to look at the external. So external is both macro, big country, and then just the external analysis of the particular area we're involved in, whether it's a focus area, for example, cancer, or it's a particular geographic area. Okay? We need to have an internal analysis of the specific system we're trying to address. We need to understand the beneficiary. In the case that Ike was explaining, it's the elderly. So we have to truly understand the population that we're trying to address. We need to know what the gaps are. What is the purpose of our program? We need to do a force field analysis. So what's hindering and what's helping? So we know which things can help us and which things we really have to control. And then we want to begin to put in what is our causal model. Why do we think this is happening? Because we need to understand, we think this is happening because, and therefore in order to change that, I must change this. Okay? Because, okay, so regular programming. Our goals are to understand the definition and rationale for monitoring and evaluation, to understand how to develop indicators within our topic for the last 3 days, an integrated people's health services system, and to understand the types of indicators and steps in developing a monitoring plan. Okay. So our outline, what is monitoring and evaluation? What is the rationale for M&E? How can we ground indicators in the integrated people-centered framework? Understand the types and purposes of monitoring and evaluation. That's very brief because we have a few minutes. How to develop indicators, and what are the steps in developing a monitoring plan. Okay, definitions. Monitoring is really the collecting and analyzing of data over a period of time, typically to measure progress towards a goal, usually using a systematic process and framework. So it's a process of systematic review. Developing the indicators is not the final step. Actually, developing the indicators is the easy part of monitoring and evaluation. Developing how we're actually going to collect the data that is credible and valid and statistically significant That's the challenge, because it can be very difficult to get at the data. Evaluation is the analysis of the data we collected in order to determine progress towards our intended results, identify and understand the unintended results, because those are important too, whether they're desirable or undesirable, understand the causal mechanisms, both for the intended as well as the unintended, for the desirable as well as the undesirable, to spot best practices, and to spot opportunities for improvement. So what should we proliferate and what should we not? To evaluate the key implementation parameters and features so we can fine-tune as necessary, and to identify the factors of success or failure. So these are the typical reasons for M&E. What is the rationale? Because we want to ensure the program outcome objectives are met. So Professor Ike showed you implementation, integration, and health outcomes, all of that. To ensure economically rational use of resources, for example, value for money. To aid in future policy decisions and or continuing implementation of programs. So to evaluate the effectiveness and or efficiency of tools and mechanisms deployed, so we can make better decisions in the future, which tools make sense for us, which don't. To evaluate implementation elements for purposes of future maintenance of the same system or improvement. Okay, how do we ground implementation monitoring and evaluation in implementation science? Okay, I'm going to give you two tools. One tool is systems thinking, specifically causal loop diagrams. The second tool is the logical framework, which you are probably very familiar with already because it's used a lot in development management. Okay, so the first thing I wanted to say is this. Sorry, how do I fix this? Sorry. Try that. Every strategy or policy is nothing but a hypothesis. If you come out with a policy, it's not necessarily right. Every policy is really, I think if we do this, this will happen. Every plan we make is just a list of these are the things we are going to do in the hope and expectation that we will arrive at the goals that we set. Do you all agree with this statement? I think Professor Ike already said it earlier, but do you understand that just because we made this policy doesn't mean it will work, right? It's just a hypothesis. We think it will work. We're confident it will work, right? But it's not necessarily going to happen. So the most important thing in implementation and in M&E is to fully understand what your theory is. Why do you think it will work? Right? So what is your theory of causal mechanism? So in this case, I'm showing you an example. So we're really just saying, what do you think is happening? So here I'm showing you, this is a Philippine example. Maternal mortality. So the goal was we want to decrease maternal mortality. We did a differential analysis. There are a lot of things, but we focused on one specific item because when we did the differentials, it looked like that was a major factor. And if we fix that, we would have fairly significant improvement. And it was this. Facility-based delivery. We needed to make sure they were delivering in the correct facility. So what's the correct facility? The first was ideally not in homes because it is very difficult to ensure hygiene, etc., in home delivery, especially in indigent communities. Second, not necessarily in hospitals because it's expensive. Okay, so the vast majority of deliveries can be done in lying in clinics with a good, well-trained midwife. So how do we do that? Well, then we asked, well, why do people deliver in homes? Because that was the thing. That was a lot of the deaths were people, indigent people, not going to facilities at all. The number one thing was no money. The second was the clinics are too far. So what's the solution? Well, let's provide the money. So this was out of the social insurance, health insurance system. So in the Philippines, you are mandatory coverage. Okay, so everyone is covered. And it is no balance bill. No balance bill means if you follow the conditions, it's all free. Okay. So how do we do it? It's only free if you go to a midwife clinic. It's not a hospital-based system. It's a lying-in clinic system with an accredited midwife and an accredited facility. However, one of the things we said was, we will also cover in a hospital if it's necessary, if it's medically necessary. How do you determine medically necessary? Well, you have to have a prenatal system. So we said you will only get no balance bill if you go through prenatal care. Because once it's prenatal care, then the midwife has the ability to say, well, you probably need the hospital. So every single accredited midwife clinic is actually connected to 1 or 2 hospitals to which they can refer. So this was an integrated system. That was the plan. What else? So essentially, we're saying we need prenatal care in order to better understand risk factors, to better understand emergent clinical condition, so we can give them the appropriate facility-based delivery so we can decrease maternal care. The most important thing we needed to fix was care-seeking behavior. We addressed that with financing, full financing contingent on correct care, so prenatal care. We actually made a major effort to increase facilities, so intensified training, intensified accreditation, intensified other support, and we needed coordination. So we needed to link lying-in clinics to hospitals. Okay. Now, given this, what do you think are necessary? What do you think are the necessary indicators? Obviously, our biggest outcome is this, decreased maternal mortality. But we also have things like how many prenatal clinics, how many clinics do we have? Right? Do we have enough? So you need to have some theory around what is your baseline. I don't have to travel more than an hour to go to a lying-in clinic, might be a good indicator. So you have to have those indicators. So you cannot have just outcome indicators. You have to have in-between indicators. Is this clear? So you have a very good sense of what you're doing and why you're doing it. This is the first most important thing in designing a program. Okay. So we begin with, based on our analysis, we believe this program will work because this is why it will work. Causal mechanism. So you can actually use what we call the log frame to document this. Okay, what's the log frame? The log frame has this. Okay, the simplest log frame is, this is what we're going to do, activities, in order to get these outputs, in order to get these outcomes, in order to get this impact. That's my goal. Okay. More complicated ones have inputs down here. And then we start with, here's the project summary. So we provide a narrative summary which things, activities, outputs, outcomes, goals, or everything from inputs, activities, outputs, outcomes, and impact or goals. So this is a summary. Okay? And we can only do this after we did a good assessment. And then we add, what are our risks and our assumptions? Essentially, now we have begun to document our hypothesis. We think if we do this, and our assumption is correct, okay? Our assumption is correct, then, so our assumption is that it is the fact that there is no financing that makes them not go to a midwife. Because if the reason they don't go to a midwife is they have some religious fear of midwives, then there's an additional thing we have to add. Okay? So our assumption is, if we do this and this is true, then this will happen. So that's essentially what we're doing here. We are able, using the log frame, to document our theory. Okay so far? Why is this helpful? Because once we have begun to run the program, and it turns out one of our assumptions is wrong, we can go back and fix the project. Okay? So this is ongoing monitoring and evaluation, which is only going to be even possible if you document it well. Okay. Next, here's what we will measure to determine whether the intervention is working. And this is now designing your actual M&E system. So you want to map your proposed interventions, how they work together in our causal loop. And for each piece, so you can't just get outcomes. At every step, you want to know, is this step working? Is this step working? Is this step working? Okay. Because then you can begin to tweak with parts of the system. Because one part might work and one part is not working. So you know which. Okay. And then you also need to figure out information gathering mechanisms. So in the log frame, you remember this bit was the summary of what you're doing. And then you did assumptions and risks. The middle piece is what indicators for each phase. What are your indicators? And how are you verifying that it's true? You notice, usually here indicators, what are the indicators? How will you collect them? And then how will you independently verify that those indicators are in fact credible? So when we're doing monitoring and evaluation, it's not just what will we measure, it's not just how will you gather it, it's also how will you verify that these numbers are true. So that is the full log frame. This allows you to document your project and how you're going to monitor it. How do you use it? Right. Once your project is running and even at every cycle, so what if your cycle is quarterly, annual? You look at everything, all the indicators, and if everything is a go, you did everything at every level, it's working, and you're getting the outcome, then the intervention is working. Here's what we do next. So in the case of PK's vouchers, we piloted, it's working. Here's what we do next. We roll it out. Or the intervention is working but needs revision. It's working a little bit, but we can improve it. This bit we can improve. We did not implement well and so can test our hypothesis. It doesn't matter if you got the outcome or not. If you didn't implement, there is nothing. Basic scientific method. Our theory is faulty. We did everything. All of the intermediate things work, but we did not get our outcome. There is something wrong with our hypothesis. Take a step back. What is wrong? Clear? So this is really just the scientific method adopted to implementation of systems. Okay, so far? Yeah, I hope so. Okay. So how do you apply public sector engagement for integrated people-centered health services into the system? What is happening? Okay. The first thing is we want to ground our analysis in the WHO frame or whatever frame you're using for integrated people-centered health services. Why? Because every system that we're studying is embedded in a much larger system. And a much larger system affects the system that we're looking at, and vice versa. Whatever we do affects the larger system. So whatever we do, even though we're focusing on our system, we also need to understand the interactions with the larger system. And this is the larger system. Example. In the case of our example, education was a critical system. We did not have enough midwives. Okay? So the only way to get more midwives is to involve education. So we need to understand at every level, macro, micro, and meso, whether there is any intervention at the macro or meso level that we need in order to make our own project work. So the WHO frame actually helps us evaluate the large system. In fact, when you evaluate the large system, it will ground all of your projects because this is your large frame. Okay? I will not belabor these 3 slides because there are 2 really big reports online on this frame. But I want you to know that the WHO actually has not just a list, but a documentation of how you evaluate your system at the macro level, at the meso level, and at the micro levels, so that you're able to say, okay, this is what it looks like, and these are the challenges. And given that these things are good, maybe this will work. Given that there are parts of the larger frame that are less than good, maybe we need to tweak our project a little bit. Okay? Okay, so when we're trying to look at our project for integrated care and involving the private sector, we need to ask, what are we trying to do? Is our focus macro? So governance policy is our focus meso. So kind of trying to get everyone connected. Do we need to connect the private care sector to the larger piece? Or is it more micro? We really just want to think about the private care physicians. Where's the intervention? Okay? What kind of integration are we after? Is it more vertical? So clinical pathways? Or is it more horizontal? We want the private sector to coordinate better with the public sector. Okay? Or is it temporal? That we need people to work together, like they're integrated, but it's too late. At this point, I want to point out, because I don't know that we spent a lot of time discussing it. There are two related things. There's one thing that's really important if we're to achieve integration, and that is sharing of information. Because you can't possibly create integrated clinical pathways if there is no sharing of the medical information. Okay? Because that is so critical. So electronic health records are critical to integration. Problem is that there is also a data privacy problem. Okay? So I think when you go home to your countries, please do not forget this, that there's I think there is no way we can integrate anything anywhere unless we solve the electronic health records and privacy conundrum. There's a solution. It's just tough. Okay. Okay. When we create a project, we need to be clear what kind of integration we're going after. We need to understand which modality do we want to use as a primary modality. Do we want to use organizational as our primary modality? Do we want to use functional? Maybe a combination. Which mechanism do we want to use? For example, Professor Yo talked a lot about strategic alliances because they are so flexible, right? But they're also, because they're flexible, a little more complex. So before we even get into our projects, we need to get a real sense of where we are, what we're trying to. And we need to identify our outcomes. Giving you a couple of ways of thinking about things. This is design thinking. It was first used in product development in the commercial sector. There are two things that are important in design thinking. Number one, you must focus completely on, in the commercial sector, the consumer. For us, the person. So the person we're trying to help. Is it the elderly? Is it smokers? Is it women? Okay? So the focus entirely has to be the point of view of the person, of your beneficiary. It cannot be just our point of view, because a lot of the problems sometimes it's our point of view. It's the policymaker's point of view. We need to look at the beneficiary. So that's the important thing. It's the audience point of view. The second thing is it's an iterative process. It's not you have this one project and that's what you do. No. And this is why we pilot, because we're not sure. You pilot, you test, you pilot, you test until you get something that you think will work. And the third is that it's a feedback-driven process. We cannot make decisions without monitoring and evaluation. We need to look at what is actually working in the field or not working. The second kind of framework I wanted to share with you is the stages of social innovation. Okay? Because really, a lot of the stuff we're doing now is just developing new things. Okay? And the stages are really very similar to product development. First is assessment. So external, internal. One of the things we recommend, and this is my area of research, is active sensing. So even when we talk about resilience, a large part of resilience is ongoing surveillance. So if you want to always be on top of the situation, you want to have active sensing. So there's assessment, and then there's ideation. Given you understand this is what's happening, let's develop the ideas. Okay? And that's a cycle. Because you have an idea, then you push it back to assessment. Oh, that might not work because the evidence says this. Next. Oh, that might work. Right? And then once you have an idea that has passed desk review, given secondary data and primary data that you have, then you can develop. And that's when you pilot test. So this is prototyping. Sometimes we do prototypes, we put them in the log frame, and then we talk to experts. Do you think this will work? Sometimes they say, no, we come back. We do not try to pilot in real life until we have pretty good consensus on a desk review based on evidence that it will. Okay? Once you have begun to pilot, that's when you can begin to systematize. Clean it until you're ready to full rollout. Once you are ready to full rollout, that's when you can institutionalize. So this is scaling up and embedding into the larger system. So this is the process that we go through. And you notice that evaluation happens at every level, even just the desk review. You're doing evaluation. Monitoring, though, begins here when you're actually prototyping. You're actually running a pilot. I wanted some important things. Design and implementation of health system interventions is an iterative process. So there's a lot of pieces here where we actually go back and forth. Design, test, pilot, test, improve pilot test. Evaluation begins actually with a desk review before even prototyping desk review. M&E begins with prototyping all the way to scaling up. The important thing is that you ensure the validity of your learnings at every stage. Because if here you're already wrong, then that's why M&E at every stage is important, so you can ensure validity. What are the types of evaluation? One way to look at evaluation is based on time. Planning stage, pre-implementation, is to make sure that we really think this program will work. What is our causal analysis? Steering during implementation. What's happening? Is this working? Oh, that's not working. Let's fix it. Post-mortem, after a year or whatever your cycle is, what went well? And then major change. There's also focus of the evaluation. Are we trying to more understand the externals and how the externals are helping the project or hindering? Or is it more the internal workings of the project? Or the phases? Is it the input that's a problem? We're not getting the commodities. Is it the process, our activities? In one of the activities, we're not getting the output. Why? Or the output is not leading to the outcome. Maybe our theory is wrong. Or we're getting some outcomes, we're still not getting real impact. Maybe it's an intensity problem. Or it's a component of the implementation. Maybe one piece is working, another piece is not. Maybe the financing is working, but there's not enough availability. It's pointless to have insurance if there is no provider. Or we can look at the elements. Is it a tool or mechanism that's misfiring? Is one of the actors not doing well? So in the Philippines, we did a really big study of whether we were getting good support from social health insurance. We thought we would get a result that said if they had enough money, like a city had a lot of money, then they would do well. So we did like how much money they had per capita versus their results. And we found generally that was true, but there were poor communities that did really, really well. Do you know what the difference was? You want to guess? The local government executive. The mayor. If the local government executive put priority on health, then the outcomes were good, even if they had small money. So this happened more than 2 decades ago. That was a big eye-opener for us. So for about a decade and a half, the battle cry of the health sector reform agenda was make health election issue. Make health an election issue, not an election issue at the local level, because it was already an issue at the national level. But at the local level, yes. Once you made health executives that were focused on health, then you get better. Okay? So it really is important for you to understand which elements have a significant effect on your impact. Okay? You can also evaluate based on the objectives directly. And then so at the macro level, meso level, micro level, by type of outcome, health versus implementation, and final versus intermediate. So the final impact on the health system versus the efficiencies, etc. And what you're testing really depends on what project you're doing. Remember, always you're testing in order to figure out what best to do in order to get your outcomes always. So don't get too evaluation happy. It takes a lot of money to do monitoring and evaluation. Don't try to monitor everything. This is why it's important to understand your theory. Just get at the big pieces of the theory and monitor those. Okay. I wanted to give you a sample that's based on one of the tools that we've been discussing. So this is accountable care organization. So essentially, this is value-based contracting. Okay? So this is using contracting and strategic alliances to improve outcomes and efficiency while building an integrated service delivery model. This is out of the United States from a paper in 2011. This was early on. If you know anything about the United States, they came out with a law in 2010, and this was one of the earliest pilots. And this was a strategic alliance held by Tufts Medical Center, and their commitment is to local care stays local out of a contract to the entire network. Okay, so this is an alliance of Tufts Medical Center, a physician network that was connected to the Tufts Medical Center and affiliated hospitals. Okay. So Apex Hospital, physician care, affiliated hospitals. So if you look at what are the integration modalities at this point, contract level, normative, project. So normative, what is consensus on goals, consensus on means, consensus on values. Clinical, this entire system had to follow a single set of CPGs. At this point, organizational. This was a big piece, the organizational network. And functional, that they shared certain means of doing things. The physician network specifically invested in electronic solutions to create integration and alignment. So functional, professional. The AAA, so output, already impact. Improve population health. They had both process, patient, and outcome measures. This is important because they wanted to look at the entire system. They wanted to improve the individual experience of care, so customer satisfaction. And the basis for this was survey scores, and they had a baseline that they used for training so that they were aiming for improvements. They wanted to limit the increase in per capita cost. So this is like heaven, right? Everything. We want patients to be happy. We want to save money, and we want to have better outcomes. Triple win. The contract elements, global capitation for total medical expense, risk share on the budget between the physician and the physician network and the principal, potential to earn additional dollars based on improved quality scores and patient experience survey scores. Tufts Medical Centers hospital contract aligned with quality and safety metrics and incentives. Okay. So they really did choose their indicators wisely, and they embedded the required indicators in the contract. Okay. So you understand, you can actually, if you're doing your M&E well, it can help you with the contracting phase of strategic purchasing. Okay. What were the results? Statistically significant 1.9% savings in the intervention group, improvement in measures of management of chronic adult conditions and in pediatric measures. All groups received a quality bonus. The average budget surplus was 3%, which is, pretty high. Okay? And more physicians joining the network. So you see, this was multiple wins. This means they were keeping patients happy, they were getting good health outcomes, and they were keeping the physicians happy as well. Plus, they were spending less money. Wow. Okay. So these kinds of solutions were first piloted in the USA and the UK. Now they're pretty well established in many countries, including Canada, Germany, Nepal, and the Netherlands. I put in the countries for which there is research that you can read online. As of January 2014, the US Medicare reported results from the ACL experiment. So this was the pilot from 2010 to 2014 was the big pilot for the US. They said only a fraction earned the bonus, but many achieved modest cost cuts while improving quality and patient experience. Most recent data, so this was yesterday because they have a live website. As of yesterday, the shared savings program had 456 ACOs participating. 33% in one-sided, meaning bonus only. 67%, a full 2/3 in two-sided, meaning bonus as well as penalties. And there is a movement towards more people in two-sided. So if you think about the social marketing campaigns, here, they started with just bonuses. Up here, bonus. And then they started saying, well, you know, if you think you can do better, we can give you higher bonuses. But if you don't meet, you get penalties. So what happens is as people learn to be better, become more confident, they sign on to the two-sided. The other people in the bonus only, they watch the people in two-sided and go, they're getting bigger bonuses. If we got as good as them, we can sign on to two-sided. So this is an everybody wins proposition. If they had done two-sided immediately, it probably would not have worked as well. Okay? So this also shows you when we implement, we need to face well, and we need to figure out when we're implementing, how do we get the best response? Okay, so a little bit social marketing. So when we design indicators, we need to make sure that we can use it to develop both the level and direction of change. So that means we have to have a baseline. We need to know before the project is. It can be used to evaluate performance versus benchmarks, which means we need to have benchmarks. Okay? It needs to be measurable, so there needs to be a practical mechanism for collecting information and measuring the change. And also it needs to be credible, so we have to be able to verify. It needs to be actionable, so they need to be specific enough that the measurements can guide future actions. Okay? They typically come as a set and require a basic causal model or framework. This is why we recommend using a log frame and doing a causal loop. Okay? It's best to have a consultative multi-sector approach to system analysis, program design, implementation, planning, and monitoring design. Why? It improves practicability and it creates ownership and accountability. The more sectors you have involved, the more ownership you have and the more accountability you have. I am not going to spend a lot of time on this. I want you to know that in the slides you have a sample. Okay, so that you can see. This is just 1/2 of the log frame. You notice its outputs because the activities is typically the largest part of the log frame. And you can always email me for additional samples if you want. I have a slide here on developing the actual monitoring framework because this piece is technical, like actually figuring out what to measure and how. So you must identify the program goals and objectives, determine your monitoring questions, indicators, and their feasibility. How easy is it to measure this? Usually customer satisfaction is one of the most difficult to measure because if you ask the hospital, how do you know they're not influencing? So verification is important. Determine mechanisms to resolve implementation issues, identify internal and external monitoring resources and capacity. External is especially important for independent verification. Develop the monitoring work plan matrix and timeline. So if you're familiar with work plan matrices, it's who does what, when, what is needed, so everything works well. And develop a plan to disseminate and use the monitoring findings. Please do not spend so much money on monitoring and then never use the results. That's so sad. Okay. And this is why we design the monitoring plan well. We start with, this is our project, this is what we want to learn. So when you get the data, you know what you will do with it. Okay. Also remember that there's a bit of project monitoring that is just management, which is project plan. Is it working? Why is it not working? Is it because we didn't have enough people? So just basic project management. So I have 2 slides left, I think. Beyond improving implementation and ensuring achievement of outcomes, there are many other benefits of monitoring and evaluation. They help in decision making because a well-designed monitoring and evaluation plan helps you understand what's working and what's not, helps you better understand systems, helps you better understand patients and audiences. It helps you in problem solving. Again, because a well-designed M&E system allows you to understand the system better in general. It helps you engage communities and civil society organizations. One, especially if you're doing it multi-sectoral consultative, but second, also because you create an increased level of credibility, and therefore they will have better confidence in you if you have data. If it's just stories, then they're very wiry, right? But if you have data, then there's better credibility. It promotes accountability of the healthcare system and the healthcare workers. It helps in budgetary decisions. So you know where to put your money. And it stimulates learning across regions within your country, but also it stimulates learning across countries. So you can have a better understanding of, oh, okay, this country, this is the log frame. Those are the assumptions, oh, that might work for me because it's the same conditions. So what are our key messages? M&E is a continuous management process. It's not something that happens once a year. It is a continuous process. You must constantly be monitoring. Okay? Monitoring and evaluation can help improve live implementation. Okay? So it's not just every year. You use it in order to, oh, okay, something's happening. Let's do something. And this actually helps when you have a risk-based plan. So you have contingency mechanisms. M&E is critical to understanding causal mechanisms to guide policy development and program design. M&E also aids in engaging key players and creating accountability. Only if you do it well. Okay.
Some questions from the floor. Any questions?
Probably very hungry and tired. Anyway.
Hello.
Yeah.
Yeah, thank you both for the great presentations. So I think we just mentioned now about the many benefits of M&E, right? But how do you kind of, so once you develop a pilot that might be successful, maybe in like a specific region or province, how do you actually convince policymakers to implement it at the higher level, even if it's successful? Even if you have all the M&E data that's there, because sometimes there's still the challenge of like getting past the roadblock.
Yeah, there's another story, influencing policymakers. I'm sure all of you, some of you have had that lot of experience before. Yeah, I think one of the problems with the policymakers is that they think they know the problems and the solutions, and they don't like to be told, right? They don't like to be told that they haven't got it right. So I think it's a question of sometimes how you work with them, right? I think when you do policy research, you have three types of research, right? You have research for policy, so you do work to work for policy. You can do work of policy, so you review what they're doing, right? So that's what most academics do. We evaluate the policies, and then we tell them what's wrong, but they don't like to be told what's wrong, right? They only want to know what's right, right? Because there's all the political pressure, right? So when we do evaluation of government, we submit our reports, and we have got to modify some of the wording. Although it's the same thing, obviously we're not going to say things that are not correct. But instead of saying that it's failure, we need to say that it's been working, but it can be improved, right? So those sort of things. Then you have research, the research 2 and 4, and research off. And research 2 policies that we just do the research, and that doesn't matter who it is, so we just do that. So I guess one of the things about policymakers, obviously sometimes they commission research. And when they commission research, they're more likely to take note of that. So they've got certain research questions. But we can also then sometimes highlight some of the problems. Like Jonathan, we're just thinking, because I've been working for ages, and I know all of them, right? And yet sometimes it's the things that you do, they do take some notice, but they do not take it in its entirety, right? And that can be also problematic. So I guess it's really working with policy, which is the most important, because when I talk about the studies that we're doing, 2 major studies we're doing. One is on the preparedness plan, which I presented in knowledge event. That was, they didn't actually ask me to do it. They invited the tertiary institutions to submit research proposals, because during the early part in COVID. So they had a lot of money, and then we all bid for and they went through the whole thing. It was peer review. So I was the only one interested to look at that policy, but it would have just sat there, I think, But now, because after the issue, they need to look at, review their own, it's like the after action review. So because I've done that part, so they're now going to look at some of that and take it for their own purpose. And when we did the voucher study, when we did the voucher study, in fact, it was a research funded by the research grants committee, but not by the government. But then when we did that, we obviously need to talk to them. And then they said, oh, then you can do the evaluation for us. Then of course, then we can decide what's being evaluated. And then they at least start looking at it. And the other study that we did was for the, I led the report in the Hong Kong Foundation, which is a think tank. And that report, I looked at, I did 3 reports for them. One is aging. The second is how our systems are not fit for purpose. And the third is strategic purchasing. Right? And all those 3 reports, I think they read it because in all those 3 reports, the chief executive for Hong Kong came for the presentation. So at least they looked at the report, and in fact, some of the things that are being done were from the report, but it's not implemented exactly the same way as we implemented. So you need to really work with them, and of course, policymakers need to first, you need to have the credibility with them, and that what you're doing are things that the questions that they want to have answered. Because very often in academia, we just do research questions in terms of the things that we want to know, but the policymakers may not recognize the question. So very often you need to in part of the policy work, you really need to interact with the policymakers, even though they don't do it ultimately. At least you know what their thinking is. So a lot of policy research that academics do are not done in discussion with them. So what we're doing now, because having been in government, and because my interest in policy work is how I can help the system, not how I can publish, because I don't need to publish, right? And so because I know that they look like Dr. Pang was saying, we're now looking at physiotherapy, because physiotherapists, as mentioned before, in Hong Kong, they're not a primary care practitioner. They need a referral. So, but there's a pressure on government to really get, because you need to have more people in primary care. It's not just doctors, right? And a lot of nurses do excellent primary care, and pharmacists are quite important in primary care because in terms of prescribing, etc. So they're now looking at how to let physiotherapists be primary care practitioners, so they not need a referral, right? So we in fact we were approached about 2 years ago by the physiotherapy board and asked us to see whether we're interested to do a study, and it was fine, and because government was trying to change the policy. Anyway, the government didn't move, so we applied for a research grant, and we're going to proceed. And when we're going to proceed on that policy, the first thing we're doing is we are seeing the government, the policymakers, right, to really ask them what is it they're intending, because you need to know what their policy objectives are. So you really need to first, when you do policy research, you need to build in the key interviews and from the stakeholders, and of course the policy is the key one. So I guess it's really working with them, understanding, and then obviously sometimes it's very frustrating, right? Because this is what should be done, and they're not doing it, right? And they're not doing it right. So we all get very frustrated, right? So I continue to be very frustrated as well, even though I have access to them. But I also need to understand, because policymakers do not wish to be seen that they don't know the stuff, right? So it's a question of how. So my positioning now is that how can I help you, right? But they may not want me to help them. So you're very lucky if they ask you to do research after you do studies, but you need to build on that. I'm saying like Professor Laksono, he's built up his credibility. He's now working very with the government and really helping determine policies. So I guess the link. So we're also advocating, because sometimes the system, the link between academia and government, right? Because they don't see that there's this great resource that they could use, that is complementary to what government should be doing. And yet government very often, because of the behaviors of academics and of government, there's no engagement. So the researchers do exactly what they do. The government does it, and the researchers are always criticizing us, right? They don't understand what we're doing. They don't understand the policy context. But also for academics to understand that the decisions that government make, it's not just evidence-based. The decisions are based on other considerations, right? The practicality, the politics, because the policy is about politics, because it's in the nature of politics or policies is politics. And when you deal with health systems, it's about politics. So you need to understand that politics, and because many of us who work in health services do not have any backgrounds in political science. And we just think that politics is a waste of time, but it's not, right? It's understanding that in the process. Sorry, I went on. Does that gives you at least some insights? It doesn't tell exactly what you can do, right? but understand the problem.
Prof, can I say something? Because you asked at the level of pilot, which means you started something. I'd recommend before you even do the pilot to engage and to do your due diligence. Because if you're piloting something, you have a goal and you want it implemented possibly nationwide, province-wide, whatever. Before you even start the pilot, you need to know who the opinion makers are, who the big decision makers are, because they are the ones who are going to make that decision. The earlier you can involve them, the better. If they are part of the design of the pilot, then they have ownership. It is much more likely that they will listen to you. Okay, so I would involve them in the beginning. Second, so I will start it with, I have never been in a position where I needed to do academic publication. So most of my research has been very, the policymakers asked for it, where we fund something and we convince policymakers to fund it. But one of the things you want to do if you want it implemented is you find something that's important to them. So if there is a consolidated health sector reform agenda for your country, look at what the top 5 things are, what the top 5 challenges are, work on those. Because if you're working on something that's not important to the country, clearly they're not going to pay attention to you. Find something that has big impact, big coverage. That's
Any last comment or question? Yeah.
The question is, as you know, Hong Kong government is spending a lot of money, like millions of dollars, to sometimes hire external consultancy firm to do study for us and to recommend policy change. So what is your take on this? What is your belief in the value of external?
Yeah, it's a lot of consultants are a waste of money and time, because they just do the things that government wants them to do. Hospital authority spends a lot of money on consultancies. So yeah, I get the problem is, of course, the consultancies, government itself needs to have some research capability. So at least you need to ask the right questions, right? So when you ask a consultant to do a work, when you haven't identified the problem, you're not asking the right question, they'll deliver whatever you wish. So that's one of the biggest problems, because that's why I've always advocated the government itself should have some research capability, policy research capability, so that at least you know what is it, the question you need to be asked. And consultants then can help you then work out what solutions there are. And of course, I'm not a fan of consultants, because many of the consultants we have in Hong Kong really don't have the expertise. So that started even the days when I was in the hospital authority. When we started it, we had a lot of consultants like the big firms, but they're very generic. They don't understand local context. So there are very few consultants that can really help you. But they certainly, if you have a specific project, they have got expertise, right? So if you want to do some actuarial work, right, the consultants are very good, right? So there's certain things they're very good at, but you need to know what they can do, right? So my take is that government should be developing the policy research with academia, because there's no incentive for academics to do policy research, because it's difficult to publish, no impact factor, difficult to progress, right? I don't need to progress, I need to retire. So that's fine. But I think Seven always advocating that they should work with, generate a cadre of policy research that can complement the things they do, but they need to develop some capability themselves. Right? So if you ask me, there are very limited things that the generic consultants can do in the health service, because they're so complex. And which takes me to finally, because you go for lunch, many of the things in health, like Maya also told you, when you look at the whole system, they're so complex. There's so many variables. So what we're trying to do to tell you is not that you have got to look at you have got to change the whole thing. But even when you change it, it's going to be very complicated. There are little pieces there. But what I'm trying to advocate too is that you need to see that in the context of the big picture, right? So that what you do is makes a progress in the consistency of what you're trying to do, and not be synergistic. Because sometimes the things you do might be even more detrimental to your overall goals. So to understand the context, and you know that you need to build up step by step, it's going to take a long time. So we have all these ideas of how to better integrate. But if you have the ultimate outcome, so I was trying to say, to me, the ultimate outcome is that the care provided to the patient is accessible, comprehensive, and it's continuity of care, right? So if you look at whatever studies you do, even if it's a small part, does it contribute to that? If it does, then it's part of the system. So you gradually move towards that as objective. So you define what your outcomes are, right? That's important, right? You need to define your outcomes. Then you can see in terms of how the process that you built, the interventions contribute to that and contribute to the bigger picture. Right? Okay, I think you better go for lunch. We can continue later. Later, Professor Chen, Sophie Chen was the previous Secretary for Health, right? And she's very kindly come later on to moderate in the presentations. So you all have 10 minutes to do a brief presentation about the issues and the solutions. And then Professor Chen will moderate, she'll comment, and then we'll also have a panel of our faculty also to discuss some of the issues, right? So make sure you have a very, very brief presentation. And because she'll be coming later, and then she'll be here with us for 2 hours. So have a good lunch.
Yeah. So lunch is as foyer, ground floor. Yeah. So please be reminded to bring your jacket down because the air conditioner is very cold right there. Yeah. Sorry for that.
Bapak Ibu, saat
Recording
ini kita
stopped.
akan masuk sesi istirahat. Saya silakan Bapak Ibu jika mau istirahat dulu, dan nanti kita kembali pukul 2 waktu Hong Kong ataupun pukul 1 waktu Indonesia. Terima kasih.
bahan kain panjang apa kain drill nggak ada kan? Ini dibawa kah? Apa? Apanya? Ini kita. Cantiknya. motor kak. Motornya masuk ya.
Halo. OTW di jalan sudah. Kenapa? Di jalan.
Halo, udah di jalan. Nah, apa? Dengan apa? Halo, halo, dengan apa? Oh iya, udah ada pengantar atau gimana? Mhm.
Bapak Ibu sebentar lagi itu akan masuk ke sesi presentasi kelompok. Jadi mungkin nanti mengikuti saja dulu ya.
Oh ini mau
Terima
perawatan kah
kasih.
atau
Tapi
gimana?
nanti akan ada sesi materi kok.
Ya sudah, biar dicek kaliumnya dulu aja sambil nunggu aku. Langsung di anu toh, di mana? Prodia itu kan?
At the University of Hong Kong, and she's also the former Secretary for Health of the Hong Kong government. So we
Yeah. Halo.
have here, and then
Ya, biar aja diambil diperiksa kaliumnya dulu
so
aja.
for the arrangement for this case summary today, we'll have each
Atau
group to come
gimana?
out to present what you have identified or of the issues and the solutions that they have think of. This is what we have discussed over the past 2 days, and each group will have 10 minutes presentations. And after all the 5 group presentation, we'll start the panel discussion. The panel discussion will including Professor Sophia Chen as the moderator. We will also invite our faculty members, including Professor Solo, Professor Ikeo, Professor Chen, etc., and then come out to join with us together for the discussions. So without further delay, maybe I invite the first group to come out first. The first group will be on the Indonesia case summary. Please.
Yeah, good afternoon, everyone. Thank you for the opportunity. I will present our group discussion yesterday. For Indonesia case, we are identified the challenge in the integrated healthcare issue. So we have many we identify many challenges in Indonesia to integrate the healthcare. But the main point, the issue in Indonesia is fragmented program, I mean. Nah, in the fragmented program in Indonesia, especially in the district health service and then in the primary healthcare center, we have many program, and like TB case and diabetes case, we have in the each program have a screening program, but they not integrate like TB conduct screening and DM conduct screening. But government trying to integrate the screening TB and DM, but many local government didn't have willingness to conduct the integrated screening. And then for that we identified the strategy. The first is we need to improve capacity managerial to effective and efficient and implement the program, because when we identify the challenge, the main cause, the main factor or the main cause why program still fragmented is because the managerial or coordinator programs still have limited capacity to formulate the program like that. And then also in the managerial, among managerial still didn't have collaboration to develop the program together. I mean, to develop program together. And then we still implement the strategic health purchasing to develop program. And then from the strategy, we need role government and private for the improved capacity. Currently, government have many training for managerial in the district health office or primary health care center, but we didn't have a role from private sector. And then for the managerial make collaboration, yeah, government trying to collaborate, but we still didn't we still not involve the private sector. And also in the strategic health purchasing from government or private didn't have a role for that. And next for engagement private sector, we have challenge in the limited support and resource to private info health program. Like the support, it's mean like for the policy in Indonesia, especially in the local area, we still have inconsistency policy. Like sometimes when they are establish one policy, and then for next year we will change the policy or develop new policy, and then the policy is not integrated like that. And the point, the second is less financial support for private. Is like the case is like TB in the TB program. For now in Indonesia we have we trying to implement the district district public private mix, but the government didn't have support like incentive for private sector provider to conduct the program like screening or testing. Didn't have support for private sector provider. And the third is limited capacity, capability, quantity, so complete in the human resource in the private sector. So the case is still the same, like the TB program in the private sector. They are still, when we ask why you did not involve the TB program, and the answer is, yeah, we limited human resource to conduct the case finding, to make report, just always like that every time and in every location. And so because we have problem in the policy, the strategy, we need to conduct policy analysis. Actually my background is policy analysis, and from my view in Indonesia, the policy analysis is still limited to conduct when we have problem. When we want need something, we develop the policy, but we still limited conduct the analysis. Why we need to develop the policy? What the problem when we address for with the policy? And then the second strategy is we need incentive. Yeah, incentive to help private, to help private provider. So yeah, like I say, like still limited financial support for private, and then not only incentive for doctor, but also incentive like to provide the facility in the clinic and doctor doctor individual doctor practice. And third is provide and produce the workforce that has capability and capacity to implement health program. Because when we provide the incentive, but the human resource, we not prepare the human resource. The problem in the report in Indonesia, data report always to be problem. it's not solved. Like, yeah. Thank you. Thank you for attention.
Thank you, Ree. So we come to the next group 2, which is about Hong Kong SAR.
Good afternoon, Professor Yo, Professor Chen, and everyone here. Hi, I'm Jackie, and this is my teammate Sherman. And the place that we have studied and will be presenting today to you will be none other than our home place, Hong Kong. So as it has been repeatedly mentioned in the course, the Hong Kong healthcare system runs in a dual track system in parallel. But to give you more numbers to the imbalanced equation, the public system covers 90% of the inpatient services and 30% of outpatient services. But we have only 6,500 doctors working in the public system, running 43 public hospitals, while the private system offers 10% of inpatient services and 70% of outpatient services, with 7,700 doctors engaged in the private system, running 14 hospitals. So this is a massive difference in terms of manpower. To understand the challenges and issues regarding the integration of the two healthcare systems in Hong Kong, we have to study the key differences and the factors that differentiate the two systems. The public system, most of the public hospitals are run by the hospital authority. The governance is under a stringent governance of the Hong Kong government, while the private system is mostly, although it's regulated by the ordinance of private healthcare facilities, is mainly run by hospital management and the board. The key driver of the hospital authority in terms of performance will be to observe government policies and to respond to corporate objectives. But the private system, being a free economic market, is often driven by revenue and profits. The financing, the HA, is heavily subsidized by the Hong Kong government, while in the private system is often paid by the users. The cost to user for the public system is impressively low. It's $15 per hospitalized day, no matter drug or the treatment being given to the patient on that day. And for every specialist clinic consultation, it only amounts to $10 to $17 US. The drugs and other clinical investigations are also heavily subsidized. In the private, the patient often has to pay a higher price, up to thousands of dollars a day. And there are also a lot of black box charges with a lot of unforeseeable costs added to the bill later on. Further differences, we include the ease of access. The public system is very easy to access, but long waiting time is expected, as you can see from the busy A&E picture taken here. While in the private, it's also easy to access if you are financially sufficient. And waiting time is very short, usually within days or hours. The infrastructure and patient record system, however, is a lot more developed and integrated in the public system, while the private is a lot more fragmented with variable quality. For the patient record system, in fact, we do have GPs working in the private sector that is still on handwritten record and a lot of filing in the clinic. And basically, last but not least, the patient's reasons for choosing the public and the private systems are different. For patients going for public services, it will be because of the low cost, the accessibility, they feel eligible for the service, and we have good quality service in the public. For the private, mostly because of the autonomy to choose the doctor and the treatment to receive, the comfortability, the luxury, and the short waiting time. So with that differences in mind, we will go on to talk about the challenges. So the key challenge will be the aging population in Hong Kong with rising chronic disease burden and the stringent resources. That is basically posing a great challenge and threatening our healthcare system in Hong Kong. As mentioned before, the public service is very easy to access, and the high cost differential often drives people to opt for public service rather than the private service. The health behaviors of Hong Kongers does not help either because of the doctor shopping, and very few citizens, around 25%, actually have a designated family doctor. And because of this good safety net provided by the public system, the Hong Kong citizens in general, they have lack of ownership to take care of their own health, and they will not go for, they will not so much opt for health screening in the private sector. And the asymmetrical power among different healthcare professionals also disrupt the integration of healthcare system across different disciplines. So the issues, we have identified 4, the issues of integrating the system. Basically, there's fragmentation within the private, there's lack of comprehensive care and referral system, there's lack of coordination between public and the private system across different disciplines. There is disruption in the information sharing, and the systems between the public and the private are not so interlinked. The price point is also a major difference between the two systems, as mentioned, and also the private charging often lacks price transparency and certainty that will encourage citizens to opt for. So the challenges in engaging private sector would be the lack of financial and other incentive for private doctors to join us. In terms of infrastructure, there's segregation, and there's also conflicting priority. The private doctors mostly work in solo practice, and they have very high autonomy. And currently, the PPP that we have are only limited to selected services. So now I will invite Sherman to talk about the strategies that we have thought about in tackling these challenges.
Thank you. In fact, this is a difficult task for me because, in fact, most of the options or strategies we will discuss soon would have been launched during a time when Professor Chen being the Secretary of Health, and also Professor at the time, So we would like to divide it into 3 levels: macro level, meso level, and micro level. In fact, but lots of them have been overlapping with each other. For the macro level, the existing some voucher systems so as to attract the people to the private sectors. Also, chronic disease co-care scheme, which will be launched, which has been launched recently, which is also a strategy for the attractions of the people to the private sector. And also district-based community health system, this is DHC, and also there's a lot of PPP, for example, GOPC, PPP, and also some screening program, for example, colorectal cancer screening, and also medical social collaborations, which would have to integrate different system in terms of the vertical integrations, also horizontal integrations. And also there may be a chance that healthcare financing model, if we can change it, have some modifications, not to change. If some modifications, it may have to ease the situations. For the meso level, maybe have there's some strategies, for example, strategic purchasing and also social marketing, which will help to attract, also to integrate the different system or different sectors within the healthcare system in the Hong Kong. And also for the there's some measures so as to enhance the quality of the healthcare, especially at the private sector. For example, the accreditations and also package price in order to deal with the price in transparency at the private sector. And also there may be it's still not implemented yet, but we should have a thought on the performance-based payment costs for the healthcare professionals, especially in the public sector. Also, continued care, electronic health record systems must have an important role to play in this aspect. For micro levels, as mentioned just now, this may may form a local network, not up to the level of the strategic alliance, but the local networks to help to integrate. But in fact, why we say raise strategic alliance here? Because we believe that DHC may have a more important role in order to enhance and integrations of the integration of public sector and private sector, and also the engagement of the private sectors within the territory. And last but not least, promotion of the ownership of health literacy and also patient empowerment among the general public in Hong Kong will be important in order to integrate all the system and also engage the private sector in order to help to improve or strengthen the healthcare system in Hong Kong. And that's all I would like to say. Thank you.
For the Hong Kong summary, and then we move to group 3 about Singapore.
Okay. Hello. Yeah. Hi, first of all, Hong Kong had very nice slides, so sorry that ours are not so aesthetic. So I'll be giving an overview of Singapore. So Singaporeans have actually one of the world's longest life expectancy, and the Singaporean healthcare system is known as one of the most efficient and successful in the world. And currently it's undergoing some significant reforms under a new initiative called Healthier SG that I'll be speaking about later. So approximately 70 to 80% of Singaporeans obtain their medical care within the public healthcare system. Government spending on public healthcare is quite low, so about 3% of the annual GDP. However, Singapore has ranked the first with a health index score of 86.9 in 2023. But despite all of this efficiency and these successes, Singapore is facing various challenges that I'll be addressing shortly. So just a brief background on the financing system. So I think you cannot see the very top, but I'll explain. So Singapore operates on a mixed financing system basis, whereby resources for healthcare come from MediSave, which is a mandatory health savings account for all Singaporeans, that is personal health savings account. MediShield Life, which again is a mandatory health insurance program that Singaporeans have to enroll in. MediFund, which is a safety net for Singaporeans who cannot meet any fees that are not covered under MediSave and MediShield, as well as government subsidies. So when seeking care at public hospitals, the upfront fees are already subsidized by the MOH to the public healthcare institutions. So beyond these 4 main buckets, there's additional smaller schemes such as CHAS, which is a scheme that helps low-income Singaporeans access primary care services in the private sector from private GPs. And then there's out-of-pocket fees and private insurance at the top. So the healthcare system is a dual track system as well. So the public healthcare system comprises of 3 regional health clusters: SingHealth, NHG, and NUHS. And each cluster has various institutions, so hospitals, rehabilitation hospitals, and public polyclinics, which provide primary care. So these polyclinics provide only 20% of the total of primary care in Singapore, but 45% of chronic disease care. So of course, there's a heavy burden on polyclinics and long waiting times because of this. And the reason is because public polyclinics provide subsidized care, whereas private GPs do not. So moving on to the private sector, 80% of primary care is provided by private GP clinics, but they only manage 65% of chronic disease care. As well as there's private hospitals and private specialist clinics. Let me move here. So I'll just go through some challenges. So one of the main challenges Singapore is facing is the aging population, and this produces a high burden on the health system, especially considering what I mentioned about polyclinics providing the bulk of chronic disease management. So there are long-term care facilities and aging care services provided by the private sector, public sector, as well as the third sector, so charities, NGOs. However, there's still a gap in terms of providing sufficient facilities for the aging population and financing them. Okay, as I mentioned earlier, there can be long waiting time in accessing public healthcare, especially in polyclinics. However, patients do opt for this because of the higher subsidies, which cannot normally be enjoyed in private GPs, with the exception of a few schemes, as I mentioned, CHAS, which allows the low income to receive subsidized care at private GP clinics. There's also some difficulties in IT integration, which Singapore is actually currently working on and has improved quite a bit in the last few years, but hasn't quite achieved fully. Private institutions do not have to enroll in the National Electronic Health Record system, which is used by all public institutions. And of course, that limits some sort of data gathering and monitoring and evaluation efforts, especially for primary care, whereby so much care is concentrated in the private sector. So we thought of a few strategies to solve the challenges, as I mentioned. So one would be focusing more on social marketing, community engagement, and constant evaluation, which can be participatory with the different stakeholders involved. So I mentioned Healthier SG. This is a new strategy which is trying to shift the burden of primary care to away from purely polyclinics to private GPs. So GPs will enroll in Healthier SG and be paid on a capitation basis from the government per enrolled patient. And patients will be encouraged to enroll with one lifelong GP to manage their chronic conditions. However, how do you incentivize patients to enroll with a GP and GPs to enroll in the scheme? So this is where social marketing can come into play. For example, making sure that patients understand what Healthier SG is, and also that they have an incentive for taking part, as opposed to seeking subsidized care in polyclinics. So one strategy might be to ensure that private GPs do provide subsidized care. For example, lower prices of medications, which are currently higher priced in private GP clinics as opposed to public polyclinics. For healthcare institutions, it would be important to use community engagement and stakeholder engagement to ensure satisfaction, as Healthier SG includes capitation-based funding from the MOH to the 3 healthcare clusters in the public health system. Also ensuring that there's constant monitoring and evaluation of Healthier SG from the start. For example, assessing GP perceptions of the scheme, what are their motivations to enroll or challenges. So in terms of systems level interventions, so systems level support should be provided for GPs to ensure that there's infrastructural integration between the public and private sector, as well as support for procurement, which currently GPs do independently for their own clinics. And of course, they have less bulk purchasing power than polyclinics and the public healthcare institutions. So MOH can provide administrative support or helpline to kind of have the systems level integration. Potentially, one strategy would be to also, so currently many patients go to public polyclinics because they must go to a polyclinic to obtain a referral to then specialty care and tertiary care in the public system. So if they go through a GP, they will be considered a private patient and not enjoy subsidized care. So potentially the government could look at widening the gatekeeping role to GPs beyond just polyclinics, especially GPs who are enrolled in Healthier SG. However, I think we mentioned today that it's important to understand the government's motivations as well before implementing a plan. So currently, there's a fear of overutilization of public healthcare at the tertiary and secondary level as well. So if you widen the gatekeeping role to private GPs as well, will that motivate more Singaporeans who actually could afford private care to then also go seek public healthcare and strain the system even more? So another strategy would be ensuring more integration with the social care sector. So currently, Singapore is considering social prescribing and multi-sectoral collaborations. So for example, GPs in the public or private sector referring patients out for social care interventions, whether it be aging centers in the community, sports interventions, even arts interventions. So that would be hopefully cost effective by addressing preventive health and the social determinants of health, and kind of acting as a health promotion measure. However, this requires medical social collaboration and financing mechanisms that still have to be considered and put into place. So this will require admin, training, time and staff, and also evidence of efficacy before these programs of medical social collaboration are implemented at a national level. They should be piloted, and it can be seen whether this type of public-private partnership can work and be suitable for Singapore. Singapore does already have a strong foundation of collaboration between the MOH, the public sector, and various charities, NGOs, and other community partners. So finally, one last challenge, last strategy would be solving for long-term care issues. So as I mentioned, there's a shortage of long-term care at the moment in all sectors, public, private, charity. So one solution would be to implement public-private partnerships, for example, for aged care centers. There have been some attempts in the past, some more successful than others. Also, a challenge would be or a strategy would be to ensure adequate funding to support private GPs to provide aging support, aged care support. Health USG is one way to do this, but maybe more strategies at the systems level and financing level can be explored for greater integration. For example, building stronger linkages through primary care networks. Another way would be social marketing for long-term care as well. So for example, developing home-based and technology-enabled self-management tools and ensuring that there's uptake of this among patients and among GPs who may then, lose some sort of income from this, and ensuring that there's telehealth participation from GP networks and GP clinics as well. Finally, at the systems level, we don't really recommend changing the overall system of Singaporean healthcare. It's been deemed quite successful, but there are some pathways that could be improved in terms of care integration, again, potentially allowing GPs to refer elderly patients into the private health, into the public health system once these elderly patients are enrolled with this specific GP for life as part of Health USG. And also referral from acute hospitals to community hospitals and rehabilitation centers to ensure that there's a downward referral system as well. Okay, yes, thank you very much.
Thank you. Then we move to group 4 about China's issues and its solutions about the problem.
Good afternoon, professors and everyone. A little bit different with the previous groups. We display our raw discussion notes to every one of us. So also the approach to the problem is a little bit different. We identify a particular problem for China's healthcare system and then apply the concept framework that we learned step by step. So I would like to share with you the topic of China is strengthening the healthcare promotion and preventive care in China through an integrated and people-centered primary care-led approach. So I would illustrate our utilization of the framework step by step and with some background of the China healthcare system. And in the end, I would like to particularly use smoking cessation as well as prevention as an illustration of the policy instrument that we learned. So for a little bit background, according to the framework, the first one is the universal health coverage, right? So for China healthcare system, the national medical security system is multi-level with a coverage of almost 99% of the citizens. So universal health coverage is achieved in that case. And then the next issue is the equity, quality, and efficiency of the care. According to our group mates from China, actually the equity issue is there because the citizens in their town enjoy very good coverage and very good quality of care. However, the villages, the penetration to the villages is poor, and therefore equity is an issue there, as well as the quality of care. Also in China, the healthcare system, the primary care centers are situated at the village, as well as some community health centers at the urban areas, and also small township hospital with only like 20 beds in the town, providing the primary health care. And there are county hospitals as secondary care, as well as tertiary and specialist care. With the presentation that Professor Chen that briefed us earlier on, you know, the resources is like an inverted triangle. However, the need is like a normal triangle. Therefore, the quality of care, according to our group mate and discussion, that actually, to our surprise, quality of care in the public sector is very good, but that in the private sector is poor. That no one would like to go to the private sector for in order to achieve a high quality of care. This is very interesting and very unusual compared to other countries. Or in my case, in Hong Kong, everyone would think that private sector quality of care is super. Maybe in terms of technology or expertise and specialists, but it is a little bit different from that for China. So with that assessment, we identify that our gaps of care include elderly palliative care and preventive and health promotion. So we think that health promotion can be our focus of care, and therefore we would like to do preventive care and health promotion for that integrated model. So in the private care, private sector health assessment, I have already briefly introduced to everyone the situation in China. With that, I would like to proceed to the proposed model of integration. Now, we can see that there is a vertical integration as well as the horizontal integration. For the vertical integration, we would like to integrate in an organizational way with some strategic alliance strategies. Like we can select some partners in the villages or community health center to integrate and buy their service to do healthcare promotion programs, and also smoking cessation training for the citizens. For the horizontal integration, we would like to do a professional integration. As I mentioned before, the quality of care is different in the private sector and the public sector. We believe that professional integration in a horizontal manner can achieve a more balanced quality of care. Of course, normative integration is essential to promote a goal for the healthcare goal, like smoking cessation. Oh, by the way, I would like to give a few words for the smoking problem, the severity of the smoking problem in China to everyone. Do you know that there are 50% of the men are smoking in China? And China is actually consuming 40% of the worldwide tobacco and cigarettes. So this is also the reason why we think that tobacco control is important in this country. To do that, I think policy instruments to use that we learned from the framework, and in this case, smoking cessation and smoking prevention. Our group think that regulation is of utmost importance. Legislation and law from the central government as well as at the province level must be implemented before everything. And also, we should develop new legislation on the tobacco packing design, advertisement, as well as some smoking policy in public or outdoor areas. And of course, we have to do the performance indication, develop some performance indicators for the quality assurance and encourage voluntary participation from the community health center. I think social marketing is important for smoking cessation promotion. We have to convey the correct information to the youngsters and adolescents. We can engage them in a meaningful way, and we should start the thing at school and also some with some role models or pop stars, as well as utilization of some peer pressure. For contracting and purchasing private sectors. Actually, we think that the direction is to purchase the private care, primary care practitioner, as well as the nurse in the community centers to do capacity building as well as training for such program. And also they can host the health promotion program and prescribe nicotine replacement therapy for the active smoker. However, we think that the purchasing strategy is not quite ready in China, in the country of China, with the central government policy. So in summary, our group has identified tobacco control and smoking cessation as health promotion as important in the country of China. And we have applied the framework as well as some policy instruments to apply in our case. Thank you very much.
Oh, thank you. And then here come our last group, group 5, which is about Taiwan.
Good afternoon, everyone. I am Sui Huang from the Center for Asia Pacific Resilience and Innovation, a newly established public policy think tank in Taiwan. And today, I'm hoping to share some of our group funding about the healthcare system in Taiwan regarding their issues and the challenges it is facing. So very brief background context about Taiwan's healthcare system. It's organized by one single payer, the National Health Insurance, and it covers over 99% of the population. So in a sense, Taiwan has already reached universal health insurance. And the health system is featured by a fee-for-service. And then there's a global budget payment system in place to control the budget. And it managed to keep the national health expenditure only around 6.6% of GDP, which is not even to the mid-level of the OECD countries. But it delivered the universal health coverage, and 70% of the contribution of this national health expenditure coming from the private sector, means the enterprise, the nonprofit NGOs, and also the household. Regarding the household, 30% of the contribution comes of the out-of-pocket payment. And then private sector really dominates the health service delivery in Taiwan. Private sector owns over 80% of the hospitals and over 90% of the clinics. Despite there is a hierarchical medical care structure in place in Taiwan, meaning different kinds of hospital facilities, and there is differentiated co-payment scheme in place and there's a bidirectional reference system in place. But still, Taiwanese patients, they have the full right and freedom to choose to access any kinds of healthcare facilities directly without referral. And then patients' medical records are stored in one cloud data management system called MediCloud through the NHI program. So given all this background context, we can see that health system in Taiwan is actually well recognized by the world as for its like coverage, accessibility, efficiency, and affordability. And public satisfaction towards the NHI program has constantly been over 90%. So this is all looks so great, but is it? Actually, there are some really long-term structural challenge, which is becoming more and more pressing. And most importantly, the NHI system is no longer sustainable financially. If you think about Taiwan, which is going to enter the super aging society in 2025, so the income that the NHI can generate from the like working population is becoming smaller, and the health security demand from the aging population is increasing. So the financial stress has been really huge, and the NHI system has been running constant deficit since 2017. And also, besides the unsustainable financial situation, the healthcare workers has been like facing a huge workload, constantly being overworked and facing great stress and burnout, which I can talk later. And then most importantly, the outcome of this looks excellent system design is that in the past 2 years, the average life expectancy in Taiwan, which is a high income society, is actually decreasing. So this already indicates the challenges that Taiwan healthcare system is facing. So there are some specific challenges our group discussion identified, and we believe that the most important and the root cause is regarding the payment system or the financial system. So at the original setting, Taiwan is featured by fee-for-service, but then I think in 1995, the government found that this payment mechanism will make the overall claim out of control. So to control the budget, there's later on add a global budget payment. So it leads to different healthcare providers to compete the share within a fixed budget every year. And how they competed? They made the competition based on not on the quality of the care they provide, but on the quantity they submit in the form of reimbursement claim. So this leads to the excessive competition and lack of coordination across different healthcare providers. And to address these challenges, we identify several strategies. For example, most importantly, Taiwanese government need to utilize different payment scheme to, for example, like DRG and capitation payment, and also need to provide the correct incentive to healthcare providers so they can value their being valued and being rewarded by their service in terms of the outcome of the patients rather than the quantity they supply to the service. And we also recommend regulatory change to consider increasing like a tiered system of NHI premium, so to enlarge the base of the NHI funding. Another challenge on the demand side is the overutilization of healthcare resources, mainly by the Taiwanese public. So because the patients can access like healthcare service across different levels, so it is very easy, and they develop the tendency of doctor shopping. They seek medical help, I think, two times than the average OECD countries population seeking. And this results to really like fragmented healthcare, and there's really like no continued care. And to address this challenge, we hope to strengthen the government can strengthen the referral system and to emphasize the gatekeeping role of the primary care. And there's a really important element of social marketing to change the mindset of the population that they need to actually manage of their health rather than like treating the seeking doctor as like go to the shopping mall, and to prioritize the value of health promotion so they can downplay the demand of like seeking excessive treatment. Also, there's uneven distribution and burnout workforce, which means because of the excessive competition, the doctors and nurses, they need to like work overtime to submit more claims to generate enough income. And there's a uneven distribution of health workers across different levels of care and between like big cities and rural areas. All this result to the unintegrated segmented care service. To address these challenges, like the issues before, we recommend change of payment scheme, and we recommend relocation of existing resources to emphasize more on the strengthening primary health care and the healthcare facilities in rural areas. And there's a lack of systematic integration in data management. So the NHI database is super strong, but the data they record there is more like I think for administrative purpose. And the NHI what we recommend is NHI to include more data about patients' outcome, health outcome, and the continued monitoring the health conditions of individuals. And we recommend that different hospital systems to increase this kind of data in the daily management of patients, which will help facilitate the integration of patient management. And finally, just like what we learned this morning, Taiwan demonstrated the case that there's really a lack of quality monitoring framework for evaluation of the patient outcome. So like I mentioned, the NHI database is mainly recording patient visits and recording the medical records. It's not like monitoring the health outcome, and it's not like doing continued monitoring of the patients in terms of like how healthy they are. So these are the areas that we recommend the government could adopt to like utilize external quality assurance agency to focus on the health quality, and also to make the database integrate to include the quality of care rather than the quantity of care. So just to brief conclude all these strategies we promoted, we recommended, it takes a long way for them to implement. And luckily in Taiwan, there is a general consensus among policymakers and health professionals that current system and current structure really needs to be changed. But there's lack of consensus regarding how. And the like what I'm here like learning, and the capital is doing is really to investigate the how to develop policy recommendations. And also there in Taiwan, there are some pilot programs like Taiwan DRG or like capitation payment. They have been like implemented in a really small scale, has not been able to scale up. So their impact on the overall health system has been rather limited. So we believe that it really takes leadership and courage for policymakers and stakeholders to initiate a structural reform bit by bit, step by step. But more importantly, it needs to be followed by accurate and consistent monitoring framework and evaluation process. And to do all this, we believe that luckily we are in Taiwan, that we have like extensive stakeholder engagement and wide social dialogue. These are crucial part to really engage everyone and to develop consensus and gain support to make necessary reform. So that's our group's take on Taiwan, and thank you.
Thank you for all the presentation. They are all very excellent because they let us know more about their regions. So we will now move to the panel discussions. We'll first have our panel and also the discussions on the stage first. May I invite Professor Sophia Chan to come to stage? And then I will invite some faculty members from each group to join with us. First of all, group one, may I invite Professor Lasolo? And then for group two, maybe may I invite Professor Chantel? For group three, maybe Professor Surapan. For group four, Professor Maya and also Professor Chen Yen Yao. For group five, Professor EKO. You just go, yeah, yes, okay. And then we have Dr. Brent Boutet.
Yes, so UK.
Okay, so good afternoon. Thank you very much, all the groups, for your excellent presentation. I think I want to congratulate EK because this seems to be a very high quality group in doing all these different policy analysis into the different countries that they have presented, or cities that they have presented. Obviously, I think, EK, when I look at the booklet, which I received this afternoon, I think the course has provided a very good framework, for you to work on, and also for you to think about all these different policy tools, policy levers, as well as, how best, this your current country or city is working in terms of performance as well. So I think it's really good to have not only have your presentation, but each group, I understand, would have group faculty as well. So without further ado, I would like to invite the faculty of each group to first maybe give some comments, and then at the end, after all the group faculty have given comments, then we can open the floor for questions and also different comments. How does that sound, EK? Would that be okay? So the first group.
Yes, thank you very much. Yes, I'm from Indonesia as well. So if you look at the challenge in integrated healthcare, yes, the point is when we look at in Indonesian case that the groups presented, yes, we have not so good in terms of the integration. We have, yes, I agree that. Sorry, before. 5 minutes. Yes, you have to have. You have to count. Yes. Yeah. Okay. 5 minutes. Yeah. So you will warn me if I talk too long. Yeah. You will. Yeah. Timekeeper. Yes. Okay. So yeah, the fragmentation is actually in many ways. For example, for the fragmentation between MOH and the health insurance body, because there are two big purchasers that not work very well together. This is one. And also we have also fragmentation across the level of care, from preventive, promotive, primary care, and also hospital care. And also the things that also are becoming fragmented between or across the level of government management, from the central, provincial, and the district level. So now when we look at the challenges, then how to overcome this problem? Yes, I think I agree with the challenges, but the strategy is not too clear from this group. Maybe I can add some points on this group, that we have to make like what we call like a general and comprehensive planning across actors. Yeah. So that means between MOH and National Health Insurance Scheme, they have to have more or closer planning, and then across the level of government, and also from the private sector. Okay, so this is the things that at the moment, because we have the new law on health, one of the clause in the new law mentioned that there will be more integrated planning, and it will be led by the Minister of Health. Before, the planning is fragmented. So we can imagine that if the plan is fragmented, then the implementation is also fragmented. And then one issue that's very important is about the equity of across the level, or maybe social economic groups. So at the moment, the health insurance budget is mostly used not only the poor, but the middle and the higher class, because there's a wrong perception that everybody, if she or he is sick, then the government will take care of everybody. So that is the point, that when we look at back to the issue of equity, because our tax system is not so strong like in the Scandinavian countries, then the government should have a choice, yeah, which socioeconomic groups that should be supported first. And I think the logic is for the poor first. Yes, it's very important. And how about the middle class and with the higher class of society? There are around 15 to 20 million Indonesian, and that is around 60 or 70 million people. I think 10 times than Hong Kong population. They are quite, they have some income or spending power to buy not public health insurance, but private one. So the point is we have to have a more integrative planning between commercial and public health insurance. Otherwise, everybody will rely on public health insurance that also relying on government budget, and it is very, very limited. And because our system is so big in terms of medical benefit, we don't have actually enough resources for financing everybody. So the budget from the government should be devoted for the poor. And this is the place as well, like Dr. Mubashir this morning proposed that for the remote area, it's better to have more contract activities to reach the unreached people in the remote provinces. Okay, I think this is my 5 minutes already. Okay, thank you very much, and thanks to the group number 1 work. Thank you. Yeah.
Thank you. Do other experts have comments on group 1? Work? We'll go through the 5 and then we'll come together. Okay, let's do that. Okay, perhaps group 2 then.
All right, thank you very much. So that was Hong Kong, which was very interesting for me coming from Thailand with a completely different system. So in Thailand, we have a very fragmented system. As we saw during the presentations, 3 health insurance schemes. And then coming in a day later to the Hong Kong group was very challenging to catch up with the system and the issues that are going on there. So I appreciate very much working with the group from Hong Kong, because I think what we did was exchanging a lot of experience from the different countries. Let me also appreciate the group members from Indonesia who shared their experiences. So we did actually a comparative analysis of 3 health systems, which I found very enriching. Now, looking at the work this group has put together for Hong Kong, I think they have done a really good job in identifying the challenges, prioritizing the challenges. But I think in terms of how to address the challenges, the group needs to be a bit more specific and identify which of the tools, modalities, and mechanisms to use. So, for example, one of the issues we discussed was the lack of financial incentives for private providers. So how can we address this issue? When we look at the possible solutions, it becomes very vague. When we discussed it immediately, participants from Hong Kong said, yeah, our system doesn't allow us to do this, but how can we change this? So what do we need to actually initiate such a change? So I think for the group, and I know they're all health professionals, I think it would be great if you could continue the discussion after this course and then see how to use the tools that we have discussed here to really come up with solutions to address these issues. Because there are a lot of opportunities. You have identified these opportunities, especially also thinking about co-locations, for example, the creation of networks where we can utilize public-private partnerships and cooperation. So I think this is my main comment. So thank you very much for the good work.
Thank you. Thank you. So without further ado, we go to group 3. Group 3 faculty.
Get the group number because I'm very interesting to join in the group work at the end of the day. And thank you so much. And I appreciate very much for all the group work from the presentation, but for group 3 that I work with them. At the end of the day, that you in the class, I mean that in this room, you spend the whole day with us. And then at the end of the day, you have to squeeze your brain to think about what happened to Singapore problem. And then without knowing at all from Singapore, I mean that not many of the presenters from Singapore to present on what the problem. And then so I appreciate for all the group member and for the presenter, you are excellent in presenting. Because if you listen with me in the group work, nothing in this, not many that you present, meaning you might have to work by yourself for the Singapore information. But from my observation, during when they discuss in the group, they exchange the idea, because in the group member are from Indonesia, they're from Hong Kong, they're from China, and then that. So you can see that they are from different health system. And then what suddenly they have to think about Singapore, what the challenges, what the gap, what the integrated health system in Singapore, do they want to be integrated? So in that the discussion is on and on. And I think that the group member can benefit from that discussion. Because from time to time, when we raise that issue, then the group members say, oh, my country is that, and then spend time in discussion about what happened to Hong Kong, what happened to Indonesia, what happened to China, and even Thailand, like me. So with that, from the presentation, you can see that in Singapore has more of the foreigner now, more and more. But in Singapore, health system, public system is for Singapore citizen only. Meaning that for the foreigner maybe become as a source of the revenue or income for the private sector in Singapore. And that is a very much challenge for the country, that how can you engage the private sector to the existing of the public health system. The public health system are not really to consider on the foreigner, or sorry, not only Singapore citizen, but for the permanent resident as well. With that idea, the Singapore, actually everyone might think that Singapore, it should not have any problem. Singapore is a high income country. The people be able to finance themselves, be able to pay for their own healthcare expense. And that is because of in Singapore policy. At the beginning, that I think that this is from my Singapore friend, that they told me that in Singapore, they think that they should be able to responsible for yourself first. If not, then the government or the public finance can assist you. But you must be able to help or to solve the problem yourself first. Responsibility is very important in healthcare nowadays. Right? Everyone should be the end user, should be able to consider this one. Don't allow someone else to pay for you. Meaning you must think about that first, and that will be govern your behavior for the health seeking behavior. Once you cannot be able to pay, then the government will have another fund. And that is the idea. But now later that if you listen to her that the new government policy think about of preventive care program. That is because of the aging society, the aging problem, healthcare problem, and it costs more. So with that, I think that with this, then for the Singapore had actually touched upon many of an important things that for us to think it when you back home, to think about what about the Singapore in the high, like Hong Kong is a high income country. What challenges for Singaporean and foreigner who work in Singapore? Thank you.
Thank you. Thank you. Thank you very much for your comments. So can we go to maybe group 4? Group 4 China.
Okay, thank you. Yeah, I think in the group 4 and Christine actually did a very good presentation and on behalf of the groups. I think and you EKs and that's to framework very well and just address actually is very difficult and that's the China's healthcare restructure. So I just would like to have 3 comments and so just think about that. I think and in China and we just think about how to just allocate the public and the private. So I think that's still the question and compared to other and country region or cities and I think in China I think the public is always the dominant system. But I think and we still need some private. Even the private have some weakness or some like some shortcomings. But I think and those private can do some like make this system more efficiency. So I think and so private still have the rationale to be and included in the system. So I think that's the basic, but I don't think we need and change totally and follow to other and that's the region or international experiences and outpatients should be provided by private. So that's, I think, the first. The second is the other, I think, and the EK that's a proposal also very well, and the vertical, that's the tertiary hospital and the relationship with primary health care. So I think the China government, but also a lot of international and their organization always recommend China primary healthcare led, that's integrated healthcare. So I think that's still very not in. Yeah, that's a good and for China actually is we still in the hospital led. So that's a hospital dominant all those kind of things. So I just think about the mechanism maybe in China that's a hospital, public hospital is autonomy public hospital. They have a lot of freedom. They behavior similar like those kind of a private hospital. So that's also occupy the private sectors. That's the room. But also occupy those primary healthcare. So I think and we should just change and from the mechanism. The third point, and I think just like how to control those healthcare system. I think government have its own, but the other I think insurance. Whether we use strategic and the purchasing and DRG or those capitation or performance and evaluation things and just monitor and evaluate our delivery system. So that's a kind of like balance and between the provider and also the payer. Yeah, I just report. Thank you.
Thank you. Thank you.
Yeah, I just wanted to say they actually did a lot of work and there's a lot of stuff that they discussed that they did not present anymore. We were lucky because we had, I think on the first day, 4 members plus the professor. So we did have a lot of local knowledge about China. And we were also lucky because we had people from other countries that really brought a wealth of understanding of the healthcare systems from their own countries and they asked the right questions. We kind of, because we had the professor here, we were able to identify very quickly what are the gaps, what are the concerns. And interestingly enough, the gaps that they identified, elderly care, preventive, mental health, they were all kind of primary care issues. So they very quickly said, okay, let's do health promotion, let's do screening, let's focus on smoking. And there was a great interest in using social marketing, which made sense because apparently smoking is a big issue. And someone actually said, well, you know what? Regulation. Because our cigarette packaging is still beautiful, whereas in other countries, there are scary pictures. So it all coalesced. And I think that's one of the things that's important when we try to create a program. If we can create a solution that addresses multiple issues, which in this case, you address the primary care lead. You kind of, if you're able to build it organizationally, then we can kind of address the hospital focus. And also, I think the professor and the other members from China said that primary care is a really good way for private sector to complement public sector. So I commend the group because we were able to find a particular issue that can be used to address multiple things. So it's a good starting point, I think, if they're able to do something about it. I also remember someone said, because a particular issue was, we want to keep the private sector, even though they're small and they have quality issues, but we want to keep them because they keep us on our toes. Dr. Priya, I think, said, AI. She was like, AI. Maybe if we put in AI, then we are able to help the private sector. So they got all the way to using technology in order to, so really good work.
Good. Good. Thank you. I mean, speaking about China, actually, I just came from a conference in Beijing on primary healthcare. So really, I think the country is moving forward towards primary healthcare. The conference is organized by Peking University, but supported by the World Health Organization and also the National Commission for Health. So all the very, very high level people were there. And obviously, I think with the deliverable of this conference, actually, there is a Beijing initiative offered, from the conference group. And so therefore, what I'm trying to say is, China is really embarking on, primary healthcare, because I think everybody knows if we do not, go forward with this strategy, the existing situation of aging population as well as chronic disease issue would not be sustainable. So therefore, financially, I think would have to go forward this way. Okay, so finally, let's go to the fifth group. Yes, thank you, Taiwan.
Thank you. Thank you, Doctor. Thank you so much. We were together with Group 5. We're together with Prof. PK and also Dr. Susan, with colleagues, Mr. Siwei from Taiwan himself, and we have participants coming in from China, Indonesia, and so forth. Me, particularly, I'm from Malaysia, so I don't really know Taiwan's health system. So we had a very dynamic discussion, and I think we were taught very well by Mr. Siwei as well, who presented very eloquently just now on the Taiwan health system. And from what has been iterated, there are multiple gaps identified by Taiwan itself, even though they have proceeded with their so-called national health insurance for many, many years. Some of the gaps indicators that he presented was including such as the decreasing life expectancy of the people, meaning that most of the countries, as you go and develop further, example, OECD countries, your length of stay or length of duration of life actually increase. But in their country, some of the alarming indicators would see some indications of decreasing life expectancy. And why is that happening? Even though they are so-called covered by insurance, and according to the system is that the universal health coverage is actually quite well applied, meaning that almost 90% of the population are covered and they are accessible to healthcare without the burden of financing, meaning most of the people would actually able to pay some sort of top-up or co-payment for the population itself, because they are insured, and there's going to be some competition, because once they have the basic healthcare services, they will try to, gather more services, and these are highly competitive among providers. Another issue that I think Mr. Siwe provided is that the decreasing strength of primary healthcare, and that applies, human resource are actually not well applied. You don't have enough doctors in providing primary healthcare. They are considered as substandard between the clinicians and also the primary healthcare providers. And there's also a difference in how they are being paid as well. And there's no incentive for the primary healthcare providers to provide more services, which is a bit different with other countries, has been mentioned. And I think our participants from China provided some very good example of how primary healthcare is actually strongly promoted in China compared with, let's say, Taiwan. So that was some interesting comments that has been mentioned in the group. In fact, when we finished yesterday, they have not actually finished the discussion. So I think they proceeded until about 6:30 themselves, when everyone else has gone back with the shuttle. The one that stays here actually proceeded with the discussion. So they were really into it. And I think the other parts that I can comment based on what has been presented is that the uneven distribution and the burnout of the healthcare workforce. We don't, from what has been stated, there's a lot of dissatisfaction, specifically from the primary healthcare doctors. I'm not really sure of how the percentage of the resignation or intention to leave among the doctors. Is it higher compared with the private? I'm sure it is higher. And how do you overcome this? Because for you to achieve universal health coverage, you need a strong primary health care, which I don't see at this point in time from what has been discussed. How's the government going to overcome this in the very short duration? We have provided many examples like a central system. At this point in time, there's no central system. So every hospital will have their own autonomy on how they're going to collect data and what basic data should be available, especially for HRS. Without this central indicator system, it's difficult for them to do assessment and audit. And if they are going to benchmark, there's no data for them to compare between different sections of Taiwan themselves. So we propose in the group for them to set up a central so-called database system. And this can be controlled by some sort of participants, strong participants from policymakers, stakeholders, academics, and so forth, and to see how much that they are able to use this data. I think that's very important for them to move forward. Thank you very much. Yeah, I think my time is up. Yes, thank you.
Thank you. Thank you. EK?
Yeah. I was also in, but not for all of the discussion group 5. But I just wanted the general comment. I think when you look at the presentations, there are certain commonalities even across the different systems. I think we recognize that the private sector is very important, right? In every system, we need to look at what the private sector does and how we work with private sector. The second is that there is private between the different levels of care, because unless we look at that, we're not going to survive any system. So this is not just Hong Kong or Singapore, but globally it's a problem. And then so that's why WHO talks about the primary care-led integrated care, and that's an ambition. It's not easy to do. And when you look at all the systems, one of the problems that sometimes we want to have a simple solution, but there's no such thing. And we don't look at in terms of what we have. Can we do more with what we have, right? So like Malaysia is saying that we're going to social insurance, but Taiwan already has a social health insurance. And but there are many advantages of that, because of single payer. Then when you with a single payer, then the public and private systems are the same, right? So you have a single payer, you can do it. But Taiwan has problems relating to design of their payment mechanisms, right? So that's something that they need to look at. But so there are also lessons that people can learn. And people are moving towards more capitation, right? Capitation. Singapore, I think Singapore government is now saying that because I remember in the Healthy Singapore report, they're asking the public, the 3 clusters, hospital clusters, they're going to capitate them, but they don't have primary care clinics, right? So, but then it's incentive. So if I'm in SGH cluster, if I'm given capitation, then it forces me to work with the private sector. It forces me with the private. That's what they're thinking. But of course, that's the thought. But how it's being done and the mechanics is something else. So one needs to look at, but certainly the payment mechanisms are a key. So whatever country we have or which systems, the payment mechanisms, your strategic purchasing, is a very, very important part. So government never thinks itself as doing the strategic purchaser, but government, as government, if you are in the tax-based system, you are the purchaser, right? Because you are responsible for all those things. But so the concept of strategic purchasing is that it's really how you identify the key things that you use, and then what are your levers. So the payment mechanisms are so important, and then looking at your different populations. So to me, the different the capitation model is and the strategic purchase are one of the important tools, right? Unless you change the whole system, and then your organization networking. How do you then get people to work together? So we did talk about some of the networking arrangements, and I found the strategic alliance to be quite useful as a concept, because in the organization forms you can either get people to form a company, but many people don't want to do it. So when you have a lot of these providers, how do you get them to work agreements? Because your purchasing body has a very powerful tool, because when I'm starting to purchase, then I'm going to purchase only from groups. So then people will then have to work together, and they don't have to give up their autonomy, but they need to have agreements. So the strategic purchasing, the strategic alliances, is that they then need to come to an agreement. So they don't have to, it doesn't have to be one organization. So the clinics can work with GPs, but they have an agreement, right? So the model that in Kaiser Permanente, right? Kaiser Permanente is a very, very successful organization. There are 3 separate organizations. They're independent. So there's the insurance one, there's the provider, the hospitals, and then the doctors. And they have an exclusive arrangement between 3 of them, but they're 3 independent organizations. So that concept of having agreements, and they can be written in terms of agreements that are legally binding, right? Then the government can also contract with them, because the government, it's easier for government to contract with a group than to individuals. So I was telling Fei Zhao, how are you going to monitor, in fact, 50,000 or 10,000 doctors? You can't, right? You can't, and then when you have chronic disease management, the conditions change, right? When you look at all the patients that come to you in your chronic disease, there's a whole spectrum, right? And what you want to do is to make sure that people who do not have complications remain there, and people who have complications to deteriorate. But how is government going to monitor all that? So those concepts, the organization models, are quite interesting for me, and those are things that we need to work on. Obviously, for the groups, you can't expect me to be able to give the complete solutions to all your problems in such a short time. But I think the groups that you've done marvelous jobs. But to start thinking about how are you going to use whatever you've learned here and start looking at your own system.
Yeah, thank you. Thank you for giving very good guidance as well. I also want to, echo the experts and also EK in letting you know. I think, all the presentations have actually done policy analysis and also your system analysis, that you've actually identified, some of the issues, the problems based on, the framework provided to you. I think, those are good. But at the same time, I don't see a lot of strategies or suggestions on how to solve the problem. Of course, you only have 10 minutes and perhaps also in the presentation, and also, in the last 3 days is a very short time. But I think, if you have that framework in mind, that I think, when you tackle or when you come across, some of the policies or strategies, in your own healthcare system, then you'll be able to think further, how best to, change, or how best to provide your leadership or your suggestion in terms of shaping, the hospital. While, I think, EK and myself have our experience of being a secretary, but I think, you don't really have to be a secretary in order to change things. Really, that's really my belief. Everybody at your own level can actually, have your own policy in your own right, and then you can make change, you can advocate. I have 4 points, that hopefully can sort of help you to, think things through. First is I also have 5 minutes, so I will, so I will be short. So first is policy, policy, and policy, whether there is policy from the top. All these governance frameworks are all, coming out from policy, and policy obviously relate to policy makers, whether they have the commitment to change and whether they have the leadership. So those are very, very important. Secondly is resources. If you don't have resources, it's all just lip service. No matter how many blueprints that you have, how many strategic documents, frameworks, if there is no resources, it got to be slow. So one must have resources. And of course, resources come from where, UK knows about it. Resources would have to come from the government, the organization, the healthcare system. If we talk about strategic purchasing, it also have to have resources. The Hong Kong government have given 10 billion, for strategic purchasing. Initially, it is for the hospital authority, but later now, the government have set up a strategic purchasing office where they will look at both primary, secondary, and tertiary care strategic purchasing. So that would give it a system and also resources. And resources not only are financial resources, I think people resources as well as land resources, if we are going to create some system. So that is the second part. The third part is operation. If you have strategy, you must know how to operate. So if we are, for example, if Hong Kong is pushing out the primary healthcare system, what are the effective models of care? Whether we have the data connectivity to actually monitor and evaluate, the system. So all these are, part of the strategies. And I'm sure, with a senior, healthcare professionals, you can offer these operational levers and operational strategies so that if there are policy, if there are resources, it still needs to roll out and operationalize. So this is the third point. My fourth point is people. People is very, very important. I mean, no matter how good we have the system, whether people subscribe to it, whether there's health-seeking behavior can be changed, whether they trust the government or any system and would abide to those systems is important. And people are not only community, we also have to take care of our healthcare professionals. I'm impressed with the Taiwan presentation that they actually raise healthcare professionals burnout and heavy workload and all that, because we really have to take care of our healthcare professionals. Otherwise, no matter how good a system we have, we wouldn't have attained the quality that we require. So I think all these are important thoughts that one have to take into consideration when you are thinking about integration and resources. When EK said capitation, which I fully agree, but if we don't have the capitation resources, that's also not possible. So I offer my 2 cents, EK.
Thank you. I agree with Professor Chen, because there's so many things we can do. And obviously you're in different positions, right? But I think one of the things, like when you talk about, I was just thinking about yesterday, I met with one of the geriatricians in our system. And this chap has been doing integrative care on his own in one of our hospitals, because in our hospitals, and so in geriatrics, in neurosurgery and orthopedics, a lot of the patients there are older people, right? So in orthopedics, it's usually fracture hip. And so all these older people in the orthopedic ward, and the surgeons only look at the surgery. They don't care about all the comorbidities. And in neurosurgery, our system, these are patients are admitted with subarachnoid hemorrhage, intracerebral hemorrhage. So I said, why are they in the neurosurgical ward? It's not neurosurgery, because most of the patients don't require neurosurgery. So in the neurosurgical wards in your AHA systems, about 80% of the patients do not have neurosurgery. And they're just sitting there because the neurosurgeons are not interested in geriatric problems, right? So then the problem, this young, he's not so young now. He's been working with the neurosurgeons at orthopedics for 5 years. So he actually got together with them and said that, I'll go to the acute ward, and then you transfer to the rehab wards, and then in the rehab wards are under surgery, but he then co-cares. So his team that actually sees the patient, and then they reduce the duration of stay from, because his data was not very, so I told him that you need to provide more data, but it's not very, I don't dare to present to tell them, people, those are the results. But from what his results are, if you do that program, he's able to reduce the duration of stay from 60 days to 30 days. Right? And he said, I've been doing that all the time. I'm trying to get my manager or my CE to get some resource to institutionalize it, and nothing happened. So he's now so fed up. He's resigned. He's resigned. So I said, can you withdraw your resignation? Because I'm now working with the hospital authority head office. These are exactly the type of programs, the things that can be done. And he doesn't have any resources, additional resources. He's using his resources. So although I agree with Dr. Chen that you obviously want massive changes, you need additional resources, but we also need to look at what resources we have. How much can we control them? And the other problem that I want to share with you, when in the hospital authority, when we were first set up, when I was the first CE, the board wanted me to change the system. So I was supposed to integrate all the 16 institutions, 30 over hospitals overnight. And then the board says, EK, we expect to see visible improvements in 2 years. I said, that's fine, I want to improve things. But I said, am I getting any resources? Oh, you already have all the resources, right? It's up to you how you use it, right? So that's my how I grew up. I don't have additional resources, and I've got to do something. But now HA culture, for every new thing you do, you ask for resources, but you don't look at what resources you have. You have got a lot of resources under you, the human resource, the capital resource, the financial. What flexibility do you have to do that? So I think that's also something you need to think of yourself in terms of what can I do in my capacity. So I've learned very early, as long as you don't tell me that I can't do that, I'm going to do it, right? If I think it's going to help. As long as there's no written policy to say that this is not your responsibility or not your authority, because otherwise things don't happen. I'm sure all of you want to improve things in your own system, and there's so much one can do, and there's so much to be done. So you can all contribute at your level, and if you move up, make sure that you don't obstruct innovations, right? Right. So that's the biggest problem, because the system, it discourages innovations, discourages people from improving things. So I've been at the hospital authority to say that you've got so many good people in the system. Last time they presented some of the innovations, but they should be institutionalized. There's no use to have one or two wards doing the thing. It should be done across the system. And when I look at that, I was just saying that you should not even be doing it. The patients should not be in neurosurgical ward. So reduce the number of patients that go to neurosurgery. And how much money can you save, right? And you save also the workload. At the moment in the system is, so I think you better go back and look at the system, because those patients should not be admitted to neurosurgery, right? They should go into medicine or geriatrics, and then have a program for rehabilitation, right? So you're duplicating things, right? So how much money are you wasting there? And nurses don't like to work in shifts. So if there's more ambulatory care, so we talk about manpower, burnout, right? A lot of things are created by ourselves. The specialization that we have, you duplicate in all our systems. Because the doctors always like specialty. That's why nobody goes into primary care, because there's nothing for them to play around with, no technologies, no new breakthroughs, right? No new drugs, no new marvelous new things. So nobody cares about the mundane day-to-day problems that patients face. So that's the system needs to be changed. Sorry.
Okay, thank you. Yike, thank you very much for this example. And if I may, because you offer this excellent example, for the students, I also want to offer one example that I actually come across, at the University of Hong Kong, if I may. So I came back to the University of Hong Kong, last year, and then I set up a Hong Kong U Primary Healthcare Academy to facilitate what is doing in the government and this government primary healthcare new journey, in particular in research training, policy advocacy, as well as international collaboration. So I got a funding, from the Hong Kong U Foundation, and I wrote a proposal, and the dean asked me to present it at the faculty board. So, to sort of get everybody interested, and your example about people not interested in primary care. So the dean asked me to present it in a dean heads meeting and also the a faculty board. And after the faculty board meeting, actually a few young clinicians, assistant professors came to me, and I was very, very happy. And because actually, the usual players are family medicine, pharmacy, public health, nursing, but then these are not from these departments. And one of them, I just want to quote one example very briefly, is someone working on allergy. And he said, actually, is very, very pleased to see that we have this primary healthcare academy, and that he really want to do something because he has a very, very long waiting time, waiting to see, whether one have drug allergy. But then he felt actually over half of these people do not need to see a specialist, So he think family physicians or senior nurses like nurse consultants can actually deal with, for example, do some skin tests and some assessment to triage the system. But because these family physicians and also nurses may not have the knowledge, so he think of a primary healthcare model in first, providing a training for GPs as well as senior nurses like nurse consultants. And then, to actually roll out a primary healthcare model in, for example, in the district health centers or in a community, to actually screen off these people so that they don't have to go to the hospital authority allergy clinic, in particular, drug allergy. So I think I'm pleased because he have this mindset, even a clinician, have this mindset of improving the system and how that can happen. So of course, then because I have this resources, this Primary Healthcare Academy, I've got some pamphlets for you. You are all welcome to attend some of our seminars and even training. And so I help him, we work together, on offering training to nurses, senior nurses, as well as family physicians. And then the next step is really to roll out, this model. So I want to also echo EK in really there are young clinicians that really have a heart to do well. And I hope you, with all these education, can be one of them.
I just want, sorry, about the normative, remember we talk about integration, normative is important. And it's really the culture. When you, in fact, when I'm because I teach undergraduates as well, and I teach them health policy, and it's a challenge because they're not interested in anything other than the clinical medicine. But anyway, but when you have these, you remember yourself when you came into medicine or nursing or whatever you have, you were very passionate. You want to do something for patients. It's just that in the system, as you're being so, the socialization is such that you think that you should go into the technology specialization. So I think obviously there are a lot of young people who really are very interested in better patient care, and not just the technologies, because we keep on promoting technology. Like now, every country is saying we need to go about technologies. Right? The technology of human management is to me the most difficult technology. So those are things that even if you're in your system, to see how you can nurture people when they come in, right? So don't wait until they're really entrenched in thinking about, there's nothing else but specialties, right? Specialization. So you start early. Because I'm quite surprised because we in CU we have a program. We have these very bright young people. They can then apply to different faculties or different departments for electives. And I was quite surprised that some of these very bright young medical students wanted to do public health and wanted to work with me. So anyway, it's very good. So these are, because they're very, very bright people, very passionate about doing good for patients. And those are the types of people we need. Obviously, technology is very important, but the technology has a role, but it shouldn't be the only thing. At the moment, the way that we move in medicine, and that applies to all the systems in the world, the increasing specialization, that everything seems to be, we only need, we don't need doctors or nurses. We only need the AI and all those things to make the diagnosis. So we might as well have robots treating patients, right? But patients are very different, right? Because as I grow older, I want to be treated as an individual, right?
Thank you. So can I open to the floor and also all the experts if you have further comments, or whether the students have any comments or questions for the experts? Yes, Professor Hong Ji Tim.
Just want to echo the views of Professor Yeo about the importance of culture and also importance of mindset, because in the example cited by Professor Yeo, even if we remove all the beds from neurosurgery and go to geriatrics, if we don't find the right geriatrician in place, then it still won't work. So it's the importance that once we have got the right mindset, once we know that, once we could think along the direction that things can change, then that would be very important. I think all of you here, I think all through the last 4 days, 3 days, have been very impressed by the models, by all the systems. But I think it is important for you to go back and influence your neighbors, right? Everyone that work next to you, and so that we can spread the message and spread the mindset so that people can change, and we can get a small group of people who would act as leaders to lead to great changes. I think culture is very important in any organization, and it is the culture that impedes changes from happening. And I think most organizations are like that. But if we can kind of rejuvenate the passion in every one of us, and then that would again lead to great changes. I appeal to all of you to try to do this as a challenge to yourself.
Okay, thank you. So any other comments from the floor, or from the students? Yes, thank you. Thank you.
Thank you very much for the wonderful sharing. And implementing all the reforms or the policy, we face a very true problem, is that actually, I think I must admit, in most of the time, we are not doing very well in engaging the stakeholders. Because people who join in the steering committee or the groups, etc., are only very selected person. And sometimes they come because of they have their own agenda, but maybe for good, okay? So after saying rounds of discussion, engagement meetings, and when we implement those initiatives, we found that most people will say, especially for the private sector, they say, actually, no one's in your group really understand what's happening in the private sector. That's the most common comment I receive now, and more than 10 years ago also, I must say. So that's a bit difficult regarding engaging different stakeholders in the private sector especially.
And maybe they are very heterogeneous, but how can we improve the engagement process? That's I really want to learn from the experts and also from overseas experience. Thank you.
In fact, we did the review of the PPPs. I think Professor Eliza Wong, in fact, did the review of our PPPs about 10 years ago and published that paper. So it's really the process and who you engage. So government normally has a structure and engage a few vocal people and think that they're going to work with you, but it's not true. So, and I didn't tell, I think Fei Zhao also, at the moment he's engaging a lot of people, but when you have the informal networks, they say something very different. And it's not just the people that talk to me. There are a lot of these GPs now have a great skepticism about the co-care scheme, right? But they do not, so sometimes you need to build up the engagement mechanism, the trust that people really think that you want to address them. But usually government decides the policy and then engage. So we found the same thing with the problem with in COVID when we did the study initially, because whenever government wants them to do something, they'll ask them to come. But when you design the policies, so in the design of the policies, so it's an early engagement in the design, the co-production concept. So you decide it and then you tell me, right? And you don't know the problems, right? So government needs to really, when you do these things, you need to start engaging them in the design of the program, right? And that's and also then sometimes I suggest you can ask academics to do certain, right? So because we are now with because it started with Professor Chen on the physiotherapy. Because we now working with the government to say that we have been funded to do research. So we are in fact your mechanism really to understand issues of the private sector. So when we do the research, they're more likely to talk to us because we are not the government, right? So they're more likely to tell us what exactly they don't like and what are the concerns. So that's also another mechanism. You get the third party to do some of these studies for you, especially for major projects, or you engage them early on. But you need to build it up, and you need to really reach out very widely, not just a few select people that have always been your advisors, right? Right? Because some of them would tell you the things they'd like to know, and maybe some of them actually don't know. They don't actually know that they're not at the field, because there are many problems at the field that you need to understand. So the engagement mechanism has got to be looked at.
I totally agree with EK that the engagement, system, not only once, but of course it takes time. All these engagement takes time, and of course, government don't really like to hear, things that are against them because they have already decided the policy. Then they engage. So that would be in the way. But then I think even with that, at the different stages of the policy formulation and also implementation, probably engagement is important. Not only the first engagement, and then and then the government would think of would bake the cake and then roll out and then ask people to eat it. But then even with the baking process, then they should be also engaged. Sometimes I completely understand that because there are fundamental differences of the private sector as well as the public sector, you would never, and I say never, make them satisfied. No matter how much you give them, they will say it's not enough. So I don't think we need to worry about that, really, because that is really, in all my experience anyway. Yes.
Yeah, I think we have to look at who are the private sectors. In the case of Indonesia, actually, we have to, maybe extreme classifications. One is the non-profit, they are private, but religious origins or community movement. But in the other pool or the other extreme is the for-profit private, and they make health services for profit motivations. I think we have to be very careful in with whom we are dealing with. Yeah. In terms like Dr. Mubasir this morning mentioned about in the remote areas, I think we have to work not with for-profit private, but for the non-profit. So they have the same language with the government. But for the for-profit, maybe they think about how much we can have the profit from this activity. That's why in Indonesia, I think also in Bangkok, Prof. Siriban, now it's becoming more and more fully private, and their maybe ideology is how to make profit, but this is legal. Yeah. So I think we have to be very detailed in who are the privates. Thank you.
Thank you. Okay, so I was given an alert, that the time that the time is up. So so if there is no burning comments, may I thank you once again, especially the experts in providing, all your expert comments and also guidance, for the groups. And of course, all the active participation and efforts the students have made in making the presentation. And I hope you can all, go home with, something that is very useful for the rest of your professional career. Thank you.
Thank you. To thank Professor Chen for really coming today all the way, and for doing this, organizing this session and mediating to be the chair of this session, and to thank her for all her insights as well, and all the excellent work she's done for Hong Kong. Right. Thank you. Thank you.
I should thank EK for organizing this course, that you are also lucky that we have EK here. Thank you.
We are working. We have Siripan and Baksa.
Thank you.
Maybe you all stay here. We will take a photo together. Okay. Yeah. For yourself first, and then with the student together. Maybe Professor Siti Hong and other faculty member like Shita or Dr. Hapa Sari. Sorry, come out, and then we can take a photo together.
Bapak Ibu, hari ini kegiatannya sudah selesai. Kami ucapkan
we
terima
have prepared
kasih
some
banyak.
cakes and muffin outside. We have the tea until 4:15, and then we have the final session about the certificate presentations and also closing.
Ya, baik Bapak Ibu sekalian, terima kasih banyak sudah berpartisipasi. Kita hari ini sudah selesai dan Bapak Ibu bisa leave. Namun saya informasikan bahwa nanti hari Senin mungkin jadwalnya akan menyusul tepatnya pada jam dan tanggal berapa, kita akan ada presentasi langsung mungkin membahas hasil diskusi yang pernah Bapak Ibu lakukan, yang sudah dilakukan kemarin. Namun jika memang tidak memungkinkan, nanti Pak Mubashir akan menanggapi hasil kerja kelompok Bapak Ibu melalui kolom chat. Terima kasih banyak Bapak Ibu, mohon maaf jika ada kekurangan dan bagi yang belum mengisikan daftar hadir bisa mengisikan daftar hadirnya. Terima kasih.
Terima kasih.
Terima kasih, mohon izin live.
Hello, hello. Please go back to your seat, and we will have our last session on wrap-up, certificate presentation, and closing.
So we do the presentation, the faster you can go. Yes. But tomorrow you're going to the hospital, yeah? Hospital visit? Hospital visit. Yeah, yeah. Okay, I won't be very long. I just speak 5 minutes and then we have the certificates. So this is supposed to wrap up, but I think mainly just want to just go through that we presented these two frameworks. One's of course on the private sector engagement, which the network has been doing for many years. So I think you find it quite useful because it looks at the more macro, the system perspective, looking at the whole system, and then using that method to look at the instruments and what you can do, and then using the private sector engagement, which Sheila did, to look at how you can engage the private sector during the assessments of the public and private systems. And then this time we build in the integrated care because we know ultimately we all face the same problems. So it's very, very obvious now, two things. One is the role of the private sector needs to be looked at. The second is how we integrate care. That's why we have these two frameworks. So in our 3 days, obviously we can't give you all the complete things in terms of solutions, right? We just give you the framework so that you can start thinking about it. So in your evaluation, maybe you could also feedback to us in terms if we rank this course again, how do you think it could be enhanced? Or maybe you could think that there could be more than one course, maybe a follow-up. Because this time we used to run the course for 5 days, then we shortened it to 4 days, and this time was 3 days, right? It's very, very compressed, and that's why the group work was very compressed to just the sessions, because we also were quite able to bring in the secretary, the undersecretary, and the commissioner for primary care, and then also get the Director General from Indonesia. We're quite lucky that we were given perspective. That was interesting, but then obviously then we don't have much time to really do the casework. In the old programs that we had, in fact, there was more time doing casework, and you really had to produce a result. So I'm not sure that that's the best way to proceed, but maybe you could reflect on it and give us the feedback so we can at least improve on the course for the future. And also for yourselves, what do you think, what things can the network do to support your ongoing development, right? So if you've got any ideas, tell us so we can then work on it to see whether there are things we could do in the future. Because one of the problems with a lot of courses is that people come and they're very enthusiastic, and when they go back, then it's all gone, right? So you don't think about it anymore. And so like our leadership course, we also have the same problem. They come, they're very enthusiastic, they go back, but we try to maintain a link. So perhaps you could also feedback to the network, because the network is also building up our capacity. We have Fudan, Professor Chen is quite interested to be a member. We have Professor Pute, also interested to be a member, so we can build a capacity, so we can think about other programs that could support you in the future. Okay, that's all I want to say. Thank you. But thank you very much for coming, and also our faculty. Right? You've been a marvelous group. I think I enjoyed all your presentations, and it's just that you, in such a short time, you did a really marvelous work. Certificate.
So we come to the certificate presentation. First of all, I would like to invite Professor Lasolo to present the certificate to Group 1 and Group 2. So I will call the participant one by one, and then the photo will be taken after the presentation to the whole group. So first of all, I want to invite Group 1, Margaret Ho. I will take the photo at the end. Yeah, you just stay there. Yeah. Dr. Will Learn. Dr. Maria Learn. Miss Free Muhatini. No one in Group 1. No one. Yeah. Okay. So we can take the photo together. So we come to Group 2. Miss Alidita Ascendi. Dr. Miki Chen. Dr. Shenming Chao. Dr. Christina Mao. Dr. Yima Unita. Oh, sorry. So thank you, Professor Lasol. Oh, take a photo first. Thank you. Thank you, Professor Lasolo. Thank you. So may I invite Professor Surapan to help us to present the certificate to Group 3. So first of all, Group 3, Miss Capucine Barcelona. No. We take a good. We take good. We take a good photo. Yeah. Dr. Lily Khan. Miss Loi Lo. Miss Inda Bujin Ninshi. Dr. Lika Hu. Dr. Lika Haridia Putri. All right, sorry. Miss Saba Asim. Saba. Dr. Hong Kishu. So let's take a group photo together. Thank you. Thank you, Professor Surupan. So, Professor EKO, we go to group 4, Miss Irene Ho. Hi. Dr. Chanani. Dr. Christine Ma. Miss Peter Mudianini. Sorry. Dr. Yuan Sheng. Dr. Christiana. Okay, good 5. Good photo first. Okay, come to group 3, Dr. Chi Kern Chen. Mr. Si Hui Huang. Dr. Wei Kit Kuo. Dr. Y.C. Lee. Maybe he's not here. Next one. Miss Yassi Yabi. Oh, not yet. Okay, so you flew free together. Take a photo. Thank you very much. So it comes to the end of the policy course. Thank you all for coming and hope you have enjoyed the policy course and enjoy all the things here. Thank you.
We also need to thank Carrie and the team because she's been doing all the work quite marvelous. And without Carrie, none of this would have happened. She says, she tells me that so she's not going to do another one. So luckily next year we're going to Siripan and the year after to Laksono.
Recording stopped.